to rechargeable when
So that's off then? Okay, but is that on? Oh, that's on. Okay. Yes, please, yeah. Thank you. Hello? Can you guys hear me? Okay. Let's see. That's all right, I'll...
Yeah, I can't whistle.
Hey everybody, we might get started. Can everybody hear me? Thank you.
Very good.
Just a bit of a mic check because I'm always weird with my height and the microphones. Can everybody hear me okay? I just have to remember to lean in, but we have microphones too if we need. Thanks everyone for coming today. So I'm going to kick us off. I'm one of the 3 presenters or facilitators of this workshop today. And we're kicking it off with me and my colleague Chris Jones. So my name is Phoebe Marshall-Liu and I work for Central and Eastern Sydney Primary Health Network as a regional planning program officer. And we're all here today to talk to you about GP shared care and do a bit of a workshop around that. But Chris and I are going to kick it off with our presentation specifically around our GP shared care program in Sydney. So before I, launch into it, I'd like to start off by acknowledging the traditional custodians of the land on which we meet today. I'd like to acknowledge all of the lands across which we all work. They're many and varied, I'm sure. And I'd like to pay my respects to elders past, present and emerging. I would also like to acknowledge people, families and carers with living experience of mental health issues and a lived experience of suicide loss and recognise their valuable contributions to this work and all of the work that we do. So first, just a little bit about our region in Central and Eastern Sydney. So as I said, Central and Eastern Sydney Primary Health Network. We're not a particularly large PHN, I don't think, by geography standards, but we do have a population of 1.6 million people. So everybody knows Sydney's a little bit overpopulated. Because we have such a high population and density, we actually have a number of local health districts and specialty health networks sitting within our PHN sort of region. So up there in the sort of light green, you can see there's South East Sydney Local Health District. With the stripes, you can see Sydney Local Health District. So they're our 2 local health districts, but we also have St Vincent's Health Network and we have Sydney Children's Hospital as well. So we have lots of partners that we get to work with, which we're very lucky. Just a little bit of information as well. So in South East Sydney LHD, there are approximately 25,000 people that are living with severe mental illness. In Sydney Local Health District, there's approximately 18,500 people that are living with severe mental illness. So this means that approximately 2.68% of people in our region are living with a severe mental illness, and this we know impacts their physical health. So a little bit of history of shared care. So the GP shared care program, as we call it, has been funded through CESPN since 2017. And it really, I think Chris sort of highlighted on this earlier, it really came from a feedback from our local health districts, our GPs, and it came from a need, which you saw on the previous slide. So the primary aim of the program is to address the significant life expectancy gap between people with mental health concerns and the general population, and to mitigate this by improving integration of mental health and physical health care. So our focus is a couple of things. So certainly to provide support, as we are the PHN, to provide support to GPs to improve physical health alongside mental health. Our other focus is to increase the number of mental health consumers that are in formal shared care arrangements And we also, and I'll talk about this a little bit more, and so will Chris, but we also employ one full-time clinical nurse consultant in each of the districts as part of the program. So just a little bit about history of shared care as it relates to our regional plan as well. So Chris mentioned this earlier in the panel, but a physical health and also a shared care focus has been a priority in the Central Eastern Sydney Mental Health and Suicide Prevention Joint Regional Plan since 2019. So joint regional planning is something that all PHNs and their partners in the health districts look at across Australia, and for us and our partners, physical health and shared care has been a really important focus. So we really use that as a platform to work together to look at both primary care and secondary care services and coming from those two different perspectives. So as a bit of an example around regional planning and physical health and shared care, in our plan that originated in 2019, priority area 3 was the physical health of people with a mental illness. And this priority area saw planning partners committing to strengthening shared care arrangements and supporting GPs to address physical health alongside mental wellbeing and also various resources. So that first regional plan came not long after the GP shared care program had been funded, so we really tied it in together. In our current regional plan, we still have made sure that one of our main focuses and initiatives within the plan is improving physical health outcomes for people with a mental illness. And again, working in, because joint regional planning it's a shared platform that's there, we've put in that commitment around GP shared care within the regional plan as well, but also specifically a focus on expanding the service model. And Chris will talk about that a little bit in a minute, but yeah, we've been working together around that. So speaking of the sort of redesign process, so that's, Chris will talk about it, but that's something that's happened probably over the last year or so of the services we sort of evaluate and redesign. And I just wanted to throw up some quotes in the slide. Really, this came from our redesign process, but I think they really highlight, first of all, differing perspectives, but also just this is the kind of feedback that we heard from our GPs and people with lived experience in our community. And for us, it really highlighted the need. And I think from that GP perspective, they're sort of summarising that prevention often gets missed. There's that focus on the sort of acute presentation that's happening for that person that day. And so prevention can sometimes not be prioritised. So in those shared care arrangements, there's an ability to have prevention be more prioritised. And then again, from someone with a lived experience, commenting on that perspective of having concerns like thyroid and diabetes that exacerbate their mental health concerns, but then also having mental health concerns that they take medication for that then impact their metabolism and liver. So it's really going both ways. So a little bit about how we work with our local health districts and our GPs towards shared care. So as I mentioned earlier, at CESPN, we fund one full-time position in each of the local health districts, which is a clinical nurse consultant. We're now calling that role, for a little bit more clarity, a shared care mental health position. Our partnership really aims to facilitate those integrated pathways between the public mental health services and the GPs, again, ultimately to improve physical health outcomes of people in our community that are living with severe mental illness. It's really about coordination and collaboration. So we look at those shared care arrangements between the mental health service and GPs, and the outcomes that we see from that and the aims of that is improved screening, detection, treatment, and management of physical health, but also improved linkages to other health professionals that person might need to see, to other clinical services, and also even to psychosocial supports. And I guess just sort of a comment as well around, shared care in the regional plan as well is it's really around the fact that at CESPN, any PHN, providing those linkages to GPs and primary care and working alongside our partners at the local health district who run the mental health services that support our consumers, we utilise that platform to really enhance the shared care service and focus on joint planning. But we also, under the regional plan, aren't just looking at people with severe mental illness, so we're looking at lots of different sort of initiatives and resources across our community to improve, again, that life expectancy gap. So I think I'm handing over to Chris.
Thanks for that, Phoebe. So, as Phoebe mentioned, and as I touched on in the panel this morning, we've been fortunate enough to have a redesign of the GP mental health shared care approach earlier on this year. So, leading up to that, and again, as we've talked about this morning, a lot can happen in 8 years' time in regards to the service landscape. So that was one of the motivators for a redesign. So indeed, the range of mental health services that we commission at Central Eastern Sydney PHN had changed rapidly. So again, that's based on the population need and the co-design that we do. And again, we were fortunate particularly to have a raft of physical health approaches and other referral sources that could complement the shared care approach. So that was one part of it, but the other part was very much based on feedback that we were hearing from people that were using the service. So as Phoebe touched on before, things like a lack of clarity around the roles involved in shared care. So where does a scope of practice end? What are the opportunities for better collaboration? And probably at the top of the list, making sure that physical health remained a priority, because it stands to reason if that gets lost in the mix, and that was the original intention, and it probably should be the top of your list for a redesign. So that's kind of what we set off in regards to with our redesign partner, which was the University of New South Wales. So from that, we've been able to develop a new service model that meets the needs of primary care. So they're still based around those positions that Phoebe mentioned before, those CNC positions. And again, still with the aim to meet preventative and effective healthcare. Again, to still meet the needs of addressing chronic disease and particularly aimed at people living with severe mental illness that are receiving care at a tertiary level and obviously at a primary care level as well. So we've got up here systemic and operational barriers. So that's probably where we're at the moment in the redesign, some of the things that we're combating. One of those is we've got a range of really, really passionate and switched on GPs in the area that have been part of the program to date, but we really need to grow that workforce. And I'll talk about the incentive program that we're looking at around that at the moment. I mentioned in the panel earlier this morning, culture change is sort of something that we're looking at as well. And that extends to the work that we're doing with the CNCs in each of those LHDs. But I was mentioning to Phoebe before what we've, one of the hurdles that we've kind of had to jump is even around streamlining our approaches between the 3 different LHDs. We actually had different KPIs for each of them. The population numbers vary greatly. Just the types of presentations that they were seeing and what they were dealing with. So, finding probably the middle ground in each of those to be able to come up with a shared approach has been difficult at times, but I think we've really started to hit our stride in regards to putting that model together, and that lends itself to outcomes. So again, one of the things that I think PHNs do reasonably well is helping to measure outcomes, because they're then fed back to the department which provides our funding. So it's really important that we do that accurately and effectively. But again, we want to move beyond just the standard physical health and mental health outcomes. And again, I believe I mentioned this morning that we want to make sure that the consumer's voice is heard for each of those touch points. So if there are areas where the consumer has felt that it's fallen down in that communication approach, in following up on their needs, in being proactive about being ask some of those really pertinent questions and being involved around their physical and mental health care in a collaborative way. We really want to draw that out in regards to outcomes as well. And, we've obviously let the LHDs and the GPs that we're working with know that that's incumbent on the work that they're doing, and they're very much on the same page with us with that. So I think that's going to reap, many rewards, hopefully. The other one is around resourcing as well. So we realise that the work that is being done by professionals is this area is complex, and you don't always get neat answers and quick wins, as everyone in this room knows. So we want to make sure that the resources match the complexity of those needs there. And again, just around roles and responsibilities, we've done a lot of work just streamlining those, particularly with the LHD roles. So everyone knows exactly what they include, and again, that's known really well by the consumer as well, and the GPs working with them. So just to summarise our current challenges and how we're working through them. So one of the big ones coming out of redesign was just around low consumer engagement, and that's from a few different standpoints. So, like I said, the numbers between the three LHDs in regards to consumers involved and being supported was highly variable and probably didn't match up to the populations that we were seeing in each of those areas. And the other one was around engagement, around the consumer actually feeling that they were, leading that approach around their physical and mental health care and really feeling engaged in the process. So some of the quotes that Phoebe shared before, we've spent a lot of time listening to people's stories and what people are telling us that they need out of the program. Communication challenges between GPs and the mental health service. So as best as possible, we want to support GPs and the mental health service around bridging those communication gaps. So part of that is the C&C role, but I think Claire mentioned it in her question this morning, or it was somebody else touched on it as well. It's the difference at the moment in regards to how different GPs actually communicate with the mental health service. There's not a standardised approach for how that works. So whether it's using an EMR type service or electronic medical health record, being able to communicate, and collaborate on care plans is absolutely essential. Financial barriers to GP care. So we know that, again, when GPs are working and providing support in our program, there needs to be a monetary aspect that compensates them for that work. And again, the work isn't quick, it isn't neat, so it's often quite lengthy. And we know the toll that it can have for GPs becoming part of the program. So I'll speak to that more when I get to the incentivisation approach that we've come up with. And the last one there's just around capacity and readiness of primary care providers. So again, that's around that systemic culture change, particularly in support of severe and persistent mental illness. So again, I think there's often pockets that do this stuff really well. We need to make sure that those pockets are replicated more widely on a region rather than just being in particular instances. So our current approaches, so I mentioned incentivising GPs. So we're very much we're just coming out of our draft approach for this at the moment, hopefully ready to launch it in the new year. So what we've come up is, a process that offers things like payment, education and networking opportunities, I guess in a scaffolded type approach that really encourages new GPs to enter the fray in regards to working with this cohort, but also doesn't neglect GPs that have been part of the process for the last 8 years. And the real aim there is in recognising those GPs that have been part of the 8 years, use them in more of a senior and mentor capacity as well, and provide parts of the incentivisation model that can speak to that. So to aid that, we are looking at a range of networking opportunities and capacity building opportunities apart from the payments and education throughout next year. We even started with some initial CPD throughout this year, really focused on GPs around people with more severe mental health problems, and had really good results and really good attendance through those. And the aim there for that incentivization isn't just improved outcomes. Again, that's making sure that there's a more well-rounded systemic approach to how GPs are involved, rather than just in pockets. So we want to move beyond those smaller instances to a wider system change around how GPs are involved. So I mentioned a little bit about the education and networking. So some of the education networking to date, we've had local pharmacists involved in providing education. We've got really strong psychiatry supports in our region, so we've had some education that's focused around that as well. And obviously we'll want to be involving people and professionals that have very close ties to what they're offering in regards to physical and mental health care in the region, and giving them opportunities to meet with and be part of the education and networking for GPs. Mentioned the streamlined KPIs before. So we have got to the stage where we've been able to streamline those as best as possible, with some key differences and nuances from the three LHDs. But obviously some of the rewards of doing that, there's obviously going to be enhanced scalability. There's the ability for more collaboration, sharing of resources, and consistency and accountability. And the last one there is just alignment with other physical health activities. So I was having a chat with a few people today and just saying I feel really fortunate at times to work in the central and eastern Sydney area, and prior to that southwestern Sydney, two PHN areas that are really fortunate to have a range of not just physical health approaches that can support mental health, but just really diverse clinical approaches as well, and people that are just keen to collaborate. And it means that, again, when you come up with approaches like this, it's far easier to align those with things that exist in the system rather than having to come up with new things. And Phoebe's work in the regional plan is really crucial to that, to being able to knit a lot of that together and show people the shared direction that we're heading in. And again, I'm very proud that physical health is a focal point of where we're heading in our regional planning approach. So what would we like shared care to look like in the next 12 to 18 months and beyond for the central and eastern Sydney PHN area? So we want to continue to, in our efforts to improve communication between GPs and mental health services. So again, that's the fundamental part, and that's what really, I think that's what really helps the consumer receiving the service the most, is when GPs and mental health services are truly on the same page around being proactive around health checks, around shared goals. It's the stuff that, when the rubber hits the road, that truly makes a difference. Backing that up is the increased engagement from GPs. So the hope is that incentivization model that I've mentioned, once that starts to take flight, that will help bring on a new raft of GPs, and again recognise the ones that we've had with us for the past 8 years, as we continue to further resource our LHDs. We'll continue with the alignment and understanding of roles, and again, we'd like to see probably by the midpoint of next year whether that's started to really help with some of the outcomes, that alignment, to be able to measure that. And the last point there, just around coordination and information sharing. So beyond the CPD sessions, we've got a range of collaborative events for GPs, mental health services, and other key stakeholders. So for instance, our clozapine clinics that's been running for a number of years, they've shown a lot of interest in having an audience and better connection to GPs. So we want to make sure that, again, they're part of the approach, not just sort of operating off in parallel. So we're really, it's a fantastic opportunity that we've been able to work with Claire on this presentation. So, and we've only just met Claire in the last couple of weeks, but we've become fast friends, and Claire's actually embarking on her own shared care approach with stakeholders that she's working with. So this is really pertinent, a really pertinent sort of partnership. So we thought it'd be great for us to, to fire off some questions that we've had from Claire, being a GP that's working obviously in a different state, but albeit with the same cohort and with some of the same sort of aims. So I'm going to
Thanks, Chris.
Start
That's
off
working.
and
Good
fire over
news.
to Claire. So Claire, the first one is, what single enhancement or feature of the GP Share Care program would make participation highly compelling for GPs?
It's a great question. And no surprises, I prepared some thoughts before now. Look, I think it's already been partially covered in some of the commentary this morning and through the panels, and Chris, you did a wonderful job on the panel. I think there's probably not one single thing, there's probably two things, if I can extend to two. The first one being time and remuneration, and I commented on this earlier. We're not a salaried workforce, we're primarily small business, and we're a fee-for-service model. So we work on Medicare rebates and Medicare funding. So we charge a service, and then Medicare rebates you as the patient for the service in what they deem to be appropriate. So our time is linked with remuneration, because anything we do with our time needs to be remunerated. So I think the fact that you're incentivising is a really good move, and that will enable people who are really passionate about this space, and there's lots of them, to actually do it and give up some of their, well, I call it regular general practice work, to move into this space. And I think the other thing, which is the other thing I commented on this morning, is communication and creating less silos. Thankfully, electronic communication has come a long way. The medical fraternity is not quite as fast as other fraternities. And as I mentioned, there's lots of fax machines floating around. I would say that general practice is pretty good. We went onto electronic software quite a long time ago, and so we use our software for our note taking and letter writing and those sorts of things. The My Health record is getting more, components to it, is what I would say. It's still clunky, it's not perfect, but it is getting a few more components, and we can definitely use that to our advantage. Yeah.
Amazing. Thank you, Claire. So the next one is, what is the one thing that you think more GPs need to be aware of when it comes to the intersection of mental and physical health?
Yeah, I think it was also described really beautifully this morning, particularly by Shannon. Talking about the fact that we're looking at a whole person. We're not looking at a single mental health condition. We're not looking at only diabetes. We're not looking at only hypertension. We're not looking at only sexual health. And I think that's what GPs do beautifully, and no surprises, my presentation will describe that to you. So I think, when it comes to what should GPs be aware of, I think we are aware of our generalist scope, and that's why we do our job. That's why we love it. But maybe we need to be thinking about opportunistic care, so vaccinating when people are in the room. Again, I think we're relatively good at that, but maybe there is a bit of that hopelessness and inevitability of, is this person going to have bad outcomes anyway? I'd like to think that most GPs don't think that we are generally hopeful people, and we're advocates for our patients. So we recognise the system. And we are sort of trying to be experts in the system we're in. And of course, South Australia is different to New South Wales, which is different to WA, etc. And so we try and help our patients navigate the system.
Amazing. Thank you. And then the last one is, have you experienced any barriers personally when trying to collaborate with mental health services, and what helped to overcome them?
I think the biggest barrier that I've experienced personally is referrals. So referring into mental health services, particularly community services, in that, often I will write a referral and then it will get bounced back to me a period of time later. And then, there'll be some explainers around that. So that's really good to say, this doesn't fit our criteria because of X, Y, or Z. You go, okay, all right, I've learnt something. That service is not for this patient, and refer it elsewhere. And then 3 or 4 months later, you've got a new patient and you think, oh, great, I know about this referral pathway. And so then you refer, and then they go, oh, no, it's changed. You go, okay, cool. Lifelong dedication to learning, good opportunity. So that's probably one of the bigger frustrations, because it wastes time. But I guess, we recognise that, just like general practice, funding models change. And so a service that might have been available 3 or 4 months ago through mental health services is no longer available. And so it's just, part of the process.
Fantastic. So if you had a funded position in the mental health service that could help you with those questions, it sounds like that'd be really beneficial.
Absolutely.
Fantastic. Thanks so much, Claire. So Claire is going to be presenting in just a tick. But Phoebe and I, just wanted to provide an opportunity with any questions that you guys might have. Michael, I think you've got one up the back.
So I'm a GP and I work in a medical service. And regarding your second question, so I have worked in private general practice, but not for some time. And one of the things, like in terms of what we might want GPs to be slightly more aware of, reflecting on my own experience, I think we as GPs hold certain assumptions about what mental health services do, particularly community mental health services. And one of the things that did surprise me, but perhaps surprises me less now, is as a GP, when we have a consumer who visits, who has care provided to them by a mental health service, sometimes at quite a high frequency, every 2 weeks, every 4 weeks, we assume that they are actually holding a degree of their primary care. It just must be. That's the assumption, because they're seeing their care providers there so often. And so the assumption is, I'm not providing their primary care, actually. The mental health service is providing their primary care. But that's often, in fact, not the case, that the mental health service is largely limited in their scope to the psychiatric care and then some elements around that in terms of psychosocial support. But the overarching medical care, so the primary care, so the psychiatry plus all the other bits are often not actually addressed. They are noted sometimes, and I've seen lots of records where consumer advised to see the see the GP, but no, that exists in 20 entries over time. That is often not actually part of the scope of their community mental health care. And I think perhaps one of the messages that's quite useful, in fact, for community GPs is that the scope for community mental health teams is often actually very limited. Even in areas where we might have some physical health services, so in our area there is some exercise physiology, some dietetics, it's actually quite limited what can be provided through the community mental health team, and thus the ongoing support through robust primary care, ideally through general practice, is actually really important.
Thanks, Michael. I think that's fantastic observations, and I definitely agree that I've probably seen a lot of that around those sort of observations as well, and it speaks to, you know, what we talked about in the redesign around clarity and scope of roles, and the questions that we ask around that. So thank you, Michael. Up the front.
Hi Claire. I would like to know, how would you deal with GPs that maybe actually be risk averse, just to get them to join up to your share care program, basically from the perspective of like remuneration is great, but there might not be enough of an incentive, because having working in mental health and AOD settings in acute care and community care, there's a whole human rights things around coercive control. It's an absolute nightmare, and your Human Rights Commission, everything like that. So how would you deal with GPs who just go, nah, just from a risk averse point of view?
Yeah, that's a really good question. I think the short answer is you're not going to get all GPs, right? So I think general practice is, a mixed bag of people, and we all have different interests and special interests. And I think you're naturally going to get people who are interested, obviously, in the mental health space, and they're probably more inclined to absorb any perceived risk. And you've got other people that are very, very risk averse and then won't do that. I think in terms of those that decide to step in, or people that are maybe on the fence that are thinking, I'm not sure about this risk, what would make it feel safer for me as a clinician? Yeah, I think, obviously education is really good, and there's lots of CPD accredited activities and things through our PHN and SAPMEA and things like that. But I think the idea of being in a shared care model where you have access to your psychiatry colleagues and your mental health clinicians, mental health nurses, exercise physiologists, physiotherapists, whomever is part of that team, so that if you have a particularly high risk patient or client and you're worried about illicit substance use or suicide risk or something like that, you can have a bit of a team environment and say,
Also thinking about the legality for the GP themselves, because these practitioners, like registrars and other things in hospital settings, basically don't put certain like watch human rights and like going to deny this person, so
okay.
the legality can come back, and when it goes to court, they get into all kinds of troubles. So the treatment doesn't get applied at all. So the person ends up staying in the system for an extended period of time, when all because of a risk aversity from a legal perspective.
So things like community treatment orders and inpatient treatment orders, and yeah. 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 Yeah.
Because of the whole human rights mess and the Human Rights Mental Health Act doesn't actually always align with the Human Rights Act, and there's huge gaps and holes. So we have to really say, how do we get the GPs who really want to engage with this, right? They need to be protected as well, but also anybody who's not doing the right thing needs to be addressed as well.
Yes, very good question. I guess I'd probably ask my indemnity insurer, to be honest with you. And I think indemnity insurance in the hospital setting is different in private practice. And so certainly I feel quite reassured by my indemnity insurer. So if I have a situation where I'm a bit unsure, I'll just pick up the phone and say, look, this is my assessment. I've spoken to my psychiatry colleague. I've spoken to the mental health clinicians. This is where we're moving forward. Do you have any advice for me? Of course, that's in a perfect setting when you've got the time. There's other settings where things are more acute and you have to make a decision on the go. And I think, probably the way I would think about it is what would sort of colloquially, what would pass the pub test? So in a group of my peers, is the decision I'm making a reasonable decision, or would it be sort of completely out of scope? I think you can't, it's really frustrating, but you can't always mitigate for every single,
I just would like to see litigation to overrun these things.
Oh, I agree. Yeah.
In any direction.
Yeah.
Yeah, I agree.
Absolutely. We'll take the last two questions. So down the front here, and then we'll come to the...
So I was just wondering, from a consumer perspective, is there scope to create resources of what are the responsibilities and expectations that consumers should have of a GP? Just because, especially for young people, often we don't know what do GPs exactly do. And for young people who might have chronic illness or disability, and they're regularly in these specialist clinics, they're often told, oh, your GP should be doing that. That's what your GP is doing. Why doesn't your GP know about this? And those sort of things. So it doesn't really allow also the consumer to advocate for themselves for their own care. So is it within this program that's being developed and co-designed, is there capacity to develop resources for what expectations for consumers?
So fantastic question and observation, and it's one that I'm definitely going to take back, because I don't think we have something like that at the moment. It's probably something pretty simple that we could act on that sounds like it would make a fantastic difference. So I appreciate you bringing it up, and it'd be great. I might grab you afterwards and just get some more of your insights around that, because I think it's I don't know, it's in a way it kind of runs parallel to what Michael was just saying about assumptions before. I think sometimes there is an assumption that those things are just known, and they're, as you've said, they're quite simply not. So we'll definitely take that back and add it into the mix. So appreciate it.
I'll just comment quickly. I think it is a really important question. And I think GP training has changed over many years. Often if you look at our websites, or sometimes we have social media as well, we're so modern, we will have a list of, what our service provision is. And we'll have other flags that might be important, like LGBTQ+, logos, etc., to, I suppose, signal that, we're practitioners that are, welcoming everybody. And we have standards in our general practice to allow for access and things like that. I will talk in my presentation about all the wonderful things GPs can do, so stay tuned.
And just the last question.
Thank you. Yeah, it was a funding question actually, because I wondered how creative you had to be to find funding to incentivise the GP's participation. Where did that money come from? Because we all know the Medicare system is not sufficient. So how did you get over that obstacle?
So it's a really good question, because it's about PHNs and funding, so we always have to be creative and be quite flexible around that. So, and it's probably one of the barriers that we're trying to overcome at the moment, because in how PHNs are set up, we've got different areas of funding depending on the groups that we're trying to cater for in mental health. So in this case, it's people with severe mental illness, so it needs to come out of that funding bucket. We've got a range of programs that we fund under that. So we had to utilise some money from that bucket. the payments that the payment structure that we've got at the moment for incentivisation, we've heard back from GPs that it's fairly modest in regards to what they're being asked to do. So that hasn't been lost on us. But again, we're working with the constraints that we have. So see it probably is a bit of a pilot effort as well. And we're looking at what we can add into the model in regards to GPs being involved and being supported. That goes beyond just being monetary, but we know that that's still going to be a sticking point for some. So that's kind of where we've landed at the moment. We think that there'll probably have to be a next iteration, and we'll probably need to provide some feedback around to our funding body to say, look, this is a really, really good opportunity and a great idea, but we're hearing from GPs that they probably need a little bit more for these payment items.
Just to quickly add to that, Chris, sorry, I'm over here. And I think that also comes back to the collaboration that we really try and focus on in our regional planning, because when you get to think about creative ways of funding things, sometimes it's around what can the mental health service be doing, how can they be sort of moving things around maybe, and then, what can we be doing as well? So it's working together, definitely.
Awesome. Thanks, Phoebe. So we're going to segue now to Claire's part of the presentation. So you've already heard a little bit from Claire, but Claire's up next for a GP perspective on mental health share care. So I'll hand over to Claire.
All right, thanks everybody. So just briefly about me. So I'm a GP who works in a standard general practice down south. I'm also one of the practice principals, so I'm one of the owners of the practice. So I'm heavily involved in practice management as well and have oversight over how the team works. I'm the Royal Australian College of General Practice South Australia Deputy Chair too, so I'm here in an advocacy role primarily. And I also work one day a week in a salaried position for Shine SA, who are our sexual and reproductive health group here, doing sexual health, but also in their education stream as well. So I would also like to acknowledge country. We're here on the Kaurna land, and I'd like to acknowledge their knowledge in terms of mental health services or mental health treatments, and their storytelling that they've done for many, many years. So we had an excellent question before. What can GPs do? So I'll start off with that component of my talk. Then I'll have a chat about our challenges, and of course we like to try and offer some options for solutions. So what are the opportunities to collaborate? And then we've got some case studies, so that'll be a bit more interactive with all of us. So this is the position statement from the RACGP regarding mental health. So I think the thing that stands out for me is the recognition of general practice being centre. And I think in terms of the question you asked before, what's the role of the GP, particularly when you've got multiple other specialists involved in your care, it's to be the centre and to be the coordinator and to help you navigate those systems in the best way possible. Of course, we also talk about interprofessional collaboration, high quality education, Medicare reform. I won't bang on too much about Medicare today, it's a hot topic, but it's an important one, and well-being of the general practice team. So this is just some SA specific data in terms of our workforce. So we've got just over 3,000 GPs in total in SA, and we've got about half male and half female. So episodes of care per annum, that's over 11 million. And so we service over 1.6 million patients per year. And we're very pleased to say that our trainees, we're fully subscribed with trainees for this coming year. And we will continue to be fully subscribed. Well, I can't promise that we'll be fully subscribed, but we're getting increasing numbers of trainees being funded, which is excellent as well. So what can GPs do? Well, we are whole person care doctors. So we, of course, know about medical conditions, but we see people over a long period of time. So we often have really good knowledge about the patient's social situation, their family, what other practitioners are involved in their care, and other carers. So maybe like home nursing staff or support workers and those sorts of things. We do all the physical care stuff. We love doing a blood pressure. We love checking, heart rate, rhythm, all those sorts of things. We patch up wounds. We manage colds. We do the chronic disease management. So diabetes is a common one, COPD. We screen for those conditions. But I think in terms of mental health and how can we really improve those statistics that we were talking about earlier, it's to do with that preventive care. And as we saw, cancer is a really big issue. It's the biggest issue in terms of physical care needs for mental health patients. So we do cancer screening. bowel, breast, cervical, lung, prostate, you name it. If there's a cancer screening test, we'll be talking about it at some stage. We love to do vaccines. That's been very popular over the COVID years, but we've been doing them forever and we continue to do them. And something that's very close to my heart is sexual and reproductive health and contraception as well as all the smoking cessation, alcohol minimisation, etc. So these are some stats from our Health of the Nation report that was just released recently. And so I wanted to highlight a couple of things. So one is that 80% of patients have a preferred GP. And according to our stats, 99% of people could see a GP when they needed to. Now, that wasn't necessarily their preferred provider, but they could see a GP if they needed to. In terms of preferred provider, we saw that 67% of people could see their preferred GP. What else have we got? These are some interesting stats, particularly in terms of mental health. So in terms of presentation reasons, we saw that 71% of GPs say that mental health is a top reason for visits. 43% of people experience mental illness or mental ill health in their lifetime. And we can see that the average consultation time is gradually increasing, so 20 minutes. So for reference, getting back to Medicare, it's funded for basically 6 to 20 minutes and then 20 to 40 minutes. So you can see if the average consult is sitting right on that barrier, then that's really, a potential issue in terms of rebates and remuneration. So I wanted to give a good example and special mention to the Office of the Chief Psychiatrist here in South Australia and Dr. Mai Duong, who's a GP who works in Salin, for sharing her data and slides with me. So we saw some of this data earlier today as well. So people experience mental distress have a 21% lower vaccination rates. They're 3.2 times more likely to be hospitalised for a vaccine-preventable illness. We saw that with flu vaccines earlier, so 41% of cases. Mental health service users experience their first vaccine-preventable hospitalisation about 9 years earlier than the average population. And so we're looking at lower vaccine rates, increased exposure, and then when they're in hospital, they're in for longer and they're more unwell. So this is just another slide to prove that point. So influenza and pneumonia disproportionately affect people accessing mental health care. So I guess basically there's some more stats there, but what we're looking at is, if we can prevent this in the first place, so vaccinate people, then we're going to reduce at least some of the burden, on the individuals, but also on the tertiary system, which we know is very burdened at the moment. And it's so easy and it's so cheap to give a flu vaccine. So, many of my patients ask me for flu vaccines when they come in, and those that don't certainly get offered one. So, that's just one example. So what else can we do? Well, of course, we do mental health. So we do all gamuts of mental health and we do different levels of severity. And some of us are more skilled in it than others. And so some people will want to manage mental health in more severe states than others. But we refer when we need help. I think that's the thing. We're specialist generalists. We know that we don't know the pointy end of all the things, and we're happy to ask for help. And that's where that shared care model is really important, because if we've got good communication and we know we've got a friendly face on the other end of the phone saying, I've done X, Y, or Z, but I'm not quite sure how to optimize this, or can you see this person in this setting? So what challenges do we have? So I've touched on it. The electronic services are good. They're not fabulous. They're a bit clunky, but they're getting there. One day we'll get rid of fax machines. I think the other big issue is there's different systems. So there's different systems in different states. There's different systems within different local health networks. So I'm down south, so I'm with Salin. That is different to Carlin, which is different to Narlin, which is different to the Women's and Children's. And so, for example, if I want to refer somebody to gynecology in my Shine SA role, then I refer to Carlin using HealthLink and the electronic form. I love it. In Salin, I'm still writing a fax and sending a fax. The other challenge, which is what I hit on before, is the referral pathway, and sometimes that is changing. So when you refer to one service, you're not sure whether you're going to get accepted or not. And it can put you off a little bit. There's some services that are well worn and you know what to refer in there, and then there's ad hoc ones that come and go. But that's just part of the job. We advocate for the patient, so we're happy to do it. We've got these things called clinical prioritisation criteria. You might have seen them for other conditions. They are coming for mental health conditions, I'm assured. And our biggest challenge is time, and I would call it a gift and a curse. So it's a curse in that we only have short periods of time, generally speaking 15 minutes or sometimes a 30-minute consult. Some people work on shorter time frames, like 10 minutes. So we're always trying to fit a lot into that period of time. But it is a gift in that we know people over a long period of time. Often we do know somebody's parents, we know their partner, we know their children, maybe we've been involved in vaccinating their babies who are now teenagers, and, we're managing their sexual health needs and contraception needs and mental health alongside all of that. So I guess, what do GPs love? We love coordinating whole person care. That's why we're in the job. We really like multidisciplinary teams, and certainly that's where Medicare funding is moving, and that's certainly sort of what we're talking about today. We love collaboration, we love learning, I said it before, lifelong dedication to learning, and we really like to champion our patients because we know them so well. So what are the opportunities to collaborate? So I think, like anything, it's a collaboration. So some of the onus and responsibility is on us. We need to write good quality referrals. So the thing that I think makes a good quality referral from my end would be that identifying that we know this patient in the context of their life right now, in their social situation. We can provide collateral to the issue that's happening right now, and we can ask a specific question. I think if you send a referral that just says, please help, that's not quite as helpful as saying, I'm not sure if this diagnosis is bipolar or depression alone. I'm not sure if a mood stabilizer would be a good idea versus an SSRI, some specific questions, because we know a lot of the general stuff, but we need some assistance. And then I'm going to talk a bit about some of the essentially Medicare things that exist that we can try and use to our benefit, accepting, of course, that the Medicare rebate doesn't equate to the cost of the service provision. So we've got our GP CCMPs, lots of acronyms. They used to be called GP MPs. Basically, it's a chronic condition plan, okay? This is the MBS quote there. It used to be a lot stricter, and it certainly didn't used to sort of routinely include mental health conditions. Now, my interpretation of that would be that it certainly does. Mental health conditions certainly are more likely to last longer than 6 months, and there's a whole range of allied health professionals and collaborative care professionals that can help in assisting managing these people. We've got our mental health care plans, which is our traditional better access pathway to get psychology input, with a bit of a caveat that we've lost a couple of item numbers along the way, but perhaps the chronic disease, the GP CCMP, can move in there a little bit. And we did see extension of some of those services through COVID as well, which have been pared back again. We've got specific eating disorder management plans, and I think that's something that I often forget about, and I'm sure there's plenty of other GPs, unless you're doing eating disorder work, it doesn't necessarily come front of mind, so think about Medicare and the different tools it has. And here in South Australia, you would have probably recently heard that we have just announced that from next year there'll be training for GPs to diagnose and prescribe for ADHD, which I think is a really good step. There's really not equitable access for ADHD management, certainly not in this state, and I don't really think across the country. There's no public service to seek that diagnosis or get an assessment for that diagnosis. So the fact that we've got GPs who are interested, that are going to be appropriately skilled to at least start the ball rolling and start some treatment. It's not to say we're not going to include our psychiatry colleagues, of course we will, but maybe we can start some of that ball rolling and make it more equitable. And we've had a huge number of applicants already. So this is just more of what I've said before, secure messaging. There are some case conferencing MBS item numbers as well, so that maybe gives some remuneration. It is practically difficult. It's not greatly remunerated, but it does exist. So, think about that in a creative way. You can always give us a call, and we do really like seeing patients with their caseworkers. If they've got a regular caseworker, that not only enables the patient to maybe take more in, or the caseworker might be able to remember some things that the patient didn't, but it also gives us opportunity to get some collateral information and work out, actually, is our management plan going to work? Because there's no point prescribing something or suggesting something that the patient's not going to be able to engage with, obviously. So what do we want? Be kept in the loop, so communication. The things we can provide are collateral history and experience from our end. Maybe you know, we know that I've got a particular patient, he always likes his depot in exactly the same location. So if he was being seen by another service, I could say, look, this is the best way to deliver his medications. We like to have access to the treating team if possible to say, hey, are we on the right track or can we tweak something? And collaboration. So, first case example. So these are real cases from my private GP practice. So 38-year-old male who lives in outer metro southern Adelaide. He was diagnosed with schizophrenia in his teens. His parents live quite a distance away, like about a 5-hour drive away. His father sadly recently been diagnosed with a terminal cancer. He attends our clinic every 2 weeks for his Clopixel depot. He often attends a bit agitated, pressure of speech, ruminating on wrongdoings. He'll often be in the waiting room, sort of muttering under his breath and quite sort of distressed, but trying to hold that in. And he often talks about wanting to seek revenge on people that have previously wronged him. However, he does routinely come in for those appointments, and he does come into my room, and we always have a quick chat, and I say, you know, sometimes he's more agitated than others, but he always lets me give him his depot. And then often he will call later in the day and say, oh, look, I was a bit agitated earlier. I'm sorry about how I was. So I've got a real soft spot for him. He's a really sweet person. But he currently has no mental health input, so all of his medical mental health care is coming from us in the GP clinic. So I've got lots of ideas, but these are the questions we have for you as a group. So what are the main issues in this case? What's the role of the GP? How could mental health services have some input? What do we think is going well? What's not going so well? And should this patient be part of a shared care model? So have a few minutes to chat amongst yourselves.
I'm a bit chesty.
Oh, no, fair
And I
enough.
think
Yeah.
people start to worry about like coughing. So. All right. Thank you.
Cheers.
offer them an opportunity there, and then there could be an opportunity for you guys to work together on this. So I mean that could obviously the person with the mental health team and then they might be reluctant to synergy. Or vice versa as well. But yeah, that's generally but you know, in regards to being assessed on that kind of has to be almost a crisis. So it's like, then what do you do? Like that's a barrier. I mean, as you pick and make decisions to make the recommendations to service workers, we know that for most part, the injury is unfortunately going to be a higher crisis. They get the more comprehensive support.
All right, should we regroup? So, too much good conversation. I don't think we could stop them, can we? Yeah. Thank you. Phoebe's going to kindly come around to the different tables, and if you want to you don't have to answer all the questions, but maybe make some comments with these questions in mind. Feel free to ask me any clarifying questions about the case if you'd like. And then I'll be asking Phoebe and Chris how the shared care model would work for this patient. Let's go.
So I'll go with the first one. What are
Sorry.
the main issues in the case? It looks like the consumer still got some active psychotic symptoms. I think that's quite concerning as well. I mean, thinking about the risks, I was talking about wanting to hurt someone. Yeah, it might not be, wanting to do that at that point in time, but I think with consumers who might have, that established diagnosis, all it takes them to tip is just one particular thing. And even if he uses the wrong substance as well, it could actually exacerbate his psychotic symptoms. And who knows, what it could actually do in the community.
Yeah, that nicely describes some of the risk that I'm carrying a lot of the time. And you do have to accept that you only see him for episodic care. And
Anything else from
if you want.
I obviously thought a case management approach would really be helpful for him. This would address all the other psychosocial stresses that probably exacerbate his risk with his underlying diagnosis. And given that he lives alone, that case management input might be able to cotton him whilst he's not with you. And we really admire the beautiful relationship you have with him.
Yeah, I agree. I think just for reference, he's a very tall person, and he often, wears very dark clothing, looks down, and is often mumbling to himself. And so, again, on the risk issue, I think he is very vulnerable and a real risk in terms of misadventure. I think people could basically take him the wrong way, and he unfortunately has been assaulted and ended up in inpatient facilities from like a facial fracture perspective, and then admitted under mental health, and then discharged without much community support. So
Do we want to move on to the next question? I might go over here.
Could you just take us back to the case study for itself? Okay. So our first point would be that it doesn't say that he's psychotic. It says that he was diagnosed with schizophrenia. Our table is mostly lived experience, so I just clarify that at the start. We said he wouldn't be a candidate for shared care because he is not acute enough, because our community teams are responsible for the acute, like 3 to 10% of people with mental illness. He is being managed by you. He's not experiencing an acute episode. If that happens, yes, you can refer him, but at the moment he'd be eligible for a mental health care plan where he could get some more long-term input, or another way you could go would be the NDIS because of schizophrenia, but that depends on the impact on his life. But in terms of shared care, we all said no, he wouldn't be eligible, recognising that there are different systems interstate and that they have more levels of care between the community teams and nothing, which is what we've got in SA.
Yeah.
I'll just say from Victorian perspective, we have a, level in between whatever it's called, whether it's care in mind or whatever, and you are often perhaps in that sort of stage where they're talking about hospitalisation, but you are able to manage at home, and you would be put in contact with I used to be involved with IPC in Victoria, and they have counsellors, dental services and GPs, and they take that, case management approach. I think, I'm not sure in New South Wales, you have a similar, and Queensland, I'm pretty sure has similar, I'm not sure, but. No, it's different. It's different. No. This is through GP.
I also just wanted to make a comment about putting people in certain boxes or labels on people based on very subjective kind of, observations, like the fact that they wear black clothes. How many people at the conference today are dressed in black or primarily black? Like, I think that's where things go wrong in care, because a lot of us wear black clothes. That's got nothing to do with their mental health. They may prefer black as their favourite colour. They may just not have much variety of clothing. So I think we've got to be careful about the things that we're pulling from this scenario to be making judgments and stuff about.
I totally agree. My comment about his clothing was not about me making a judgment about what he wears. I was more commenting on how he presents in the waiting room to other patients and comments that they've made to me. And my concern for him is that he is quite a tall person and he could look concerning to other people. And people have definitely said that to me. And I'm concerned that, you know, I know him quite reasonably well as his GP, that somebody might, you know, basically assault him thinking that he was being aggressive towards them or something, which is totally not what he's doing.
I guess I just wonder, like, I think it, like, really depends on, like, the scope of care that he requires. Because, like, I think that to some capacity, I think there should be broader care. Like, for example, maybe a mental health nurse, if that's appropriate. Maybe it needs to be a psychiatrist. Maybe it's a psychologist. Maybe it's a counselor. And it also depends on, like, how much is it impacting the individual in question. Like, if these... if the schizophrenia is impacting his life in a negative manner, as there are people with schizophrenia who have very good quality of life, I guess I think that there needs to be a degree of shared community work, but I guess, like, there's I'm having kind of like a conflict of, like, how severe or how much needs to be done to ensure this person gets the best care possible. Like, does it really need to be as significant that they need to go to hospital or they need to go to a psychiatrist, or can it be managed with, let's say, a peer worker or with just, like, a mental health nurse? So I guess those are my thoughts about this case.
Yeah, thanks.
I might go back to this table. Do you want to bring up the questions if we had any specific ones you want to answer, or just general thoughts?
Most of our discussion was around the first question, the issues, and we were talking about how Depo is long-acting injectables are actually a high-risk medication, and as a GP you would naturally want some support and supervision around managing that. Another issue that we raised was the capacity of mental health services, and all of them are understaffed and having difficulty managing the caseloads that they have. And then another point that was raised was as an issue was who is actually monitoring the compliance of this fellow. You're just seeing, you're just seeing him for that brief snapshot, and what support does he have? So did you want us to go on to the next few questions? So in terms of the role of the GP, we talked about the GP having a role in escalating care when concerned and seeking or referring for assessments. And I guess there's always the Medicare 291, one-off psychiatry assessment as an option. And role of mental health services is around review and supporting decision making, and in particular specialist psychiatry in that role. I'm thinking what we didn't discuss, and I'm thinking about the parallel. With our clozapine services, we have people who are actively case managed, and then we have people who are under GP shared care who receive a regular 6-monthly psychiatry review because they're on a high risk medication, right? So I'm wondering whether that same process should actually happen for people that are on long acting injectables, that they all get a regular 6-monthly psychiatry review, and I'm not sure whether then that's just a personal thought. What else did we talk about? There's what can be improved. Support. Does he need NDIS? How's he coping with life? There's not enough in the case scenario to really know what's happening there. regular review, and it sounds like one fairly soon actually, because sounds a little bit symptomatic with some active symptoms currently. So, does anybody else want to?
I'll say something. I'm a GP. It strikes me as really odd. If he had heart failure or diabetes, he would be under the care of the GP. But if there was an exacerbation or a clinical question, the GP could immediately seek help, and maybe with heart failure, for instance, head off an exacerbation and hospitalisation.
Yeah.
But it seems in mental health care, when you get, I understand the constraints, but when you exit the community mental health team, it's the end of their care. And to go back in requires you to go to someone who doesn't know this person and is naturally resistant because of the constraints to taking someone on. And so you don't have that easy access. And I think one thing, I'd be really interested to know if you guys are addressing that in terms of making the shared care easy for the GP. They're more likely to take it on if when they're I'd be feeling really uncomfortable with this guy, and like you carrying that risk. And it's sitting there as a constant worry in your mind. Am I doing right by him, both in his treatment, but also is he a bit too sick for this? And the only way to get him back in is to send him back through the acute system, which doesn't seem right.
No,
so
and that's
to me,
what's happened,
that's a really big problem for this case.
Yeah. So the times he's had mental health specific input is when he's been so unwell that there's been some sort of misadventure, and he's ended up through the emergency department in inpatient care. He's had obviously good care while he's been in there, and very short-term community mental health input afterwards, which I absolutely accept. There's limited capacity for that, and he's likely to have some chronic symptoms. But I do think a 6-monthly or 12-monthly review just to touch base. Is this the right medication at the right dosing interval? I'm very happy to do all of his metabolic risk assessment and things like that. And I do a risk assessment in terms of his mental health every time I see him. And I think, is he his normal self? Is he a bit off today? What's going on? My big concern for him at the moment is that his dad is terminally ill. And, I asked him about that recently, and he was quite settled. And I just said, I'm really sorry. How's that going? And he became quite agitated, understandably so. And I just think, what's going to happen when his dad sadly does pass away, that's going to be a crisis for him. And I don't really want him to end up back through the inpatient service. So if I had some collaborative, input where I could help cushion that a bit, particularly given they're 4 or 5 hours away. Yeah.
I think what we might do, because we've got 3 tables left, but we have one more case study and not an enormous amount of time. So we might
just skip the last case study if you want. I think this is a good conversation.
Yeah, it's up to everyone if we want to keep talking about this case study, and we can talk about it from a PHM perspective, or if we want to launch into another one as well. Thoughts? Yeah? I'm getting 50-50. Maybe we'll stay on this one. I'm making a captain's call. Do we want to talk on it from a PHM perspective first, or keep going around tables? Yeah. Perfect. Awesome. All right, I'm going to go to you guys. Feel free to work through the questions or answer the ones you sort of spoke about most. Can I hand it to someone?
Hello, so I work with Andrew, so we're both GPs. And just to, I think it is worthwhile seeing through the sort of prism of universality that, like Andrew said, if this person had heart failure, life, it's a condition, chronic condition, never will really get better, has an effect on life expectancy. There's no question the cardiologist would say, yeah, you're going pretty well, but I still want to see you in 12 months. And it would be quite unusual, the person must be going really well, for them to say, well, probably don't really ever see you again. That's pretty uncommon. While this, for many people living with severe mental illness, particularly if they live with residual symptoms, they do live with a condition that has major impacts on their day-to-day quality of life and probably on their life expectancy. But it does become a serious challenge in trying to seek additional support when someone does appear that they're not going well. And the fact that it seems to be by exception rather than something that would just be routinely part of the process, notwithstanding, of course, there are some major limitations with public mental health services. And I think that's something that from a philosophical perspective on how the system is structured, it does lead to us as GPs holding on to risk. And I would suggest, just as a point of sort of raising, I suppose, what reality is like, every GP would probably have a few individuals like this case study. Certainly I had a few people when I worked in private general practice where I was giving their depot and they had been discharged from mental health services, nominally fairly stable, but this disquiet, this discomfort as time progresses. And just as the questions about shared care model and I think if we sort of think ideally what might be good, I think community mental health services have very limited capacity for case management. And I think with how they're staffed and resourced at the moment, that must be the case. They're looking after people who are the most unwell with the most need. But I think, it's a model that has potentially a lot of benefit, including for potentially someone like the person in the case study. Now, they may not want to have that service. And as a GP, referring somebody externally is often difficult, it's problematic. They don't want to see a new person. They don't want to be assessed again. They don't want to have to tell their story again. And as a person myself, I would if I'm meeting a new person, I would feel some degree of intrinsic discomfort until I really got to know them. And so just as a big idea, potentially, particularly with some changes with Medicare, and My Medicare exists as a notional thing, that I think there is a place for people like peer workers and mental health nurses and some form of psychosocial support, which may be case management, it may be more flexible than that, that is integrated in the community, maybe out of general practice, potentially healthcare workers, which might be shared amongst a number of general practice clinics across a geographic area. And that's a model that exists in some parts of the world, generally not in this country. That might be a way where people like the gentleman in the case study could have additional access to care. Nominally, you're not referring them to another service. They're already attending on a very regular basis to the general practice. That becomes the link for some of those additional services. Anyway, just an idea.
Following on from that, and I work in the clozapine service sector, where we do, like you say, review people every 6 months. But maybe some of it's about language. So we could refer to it as an outpatient appointment rather than we're referring you back to mental health. It's because, the 219s, they're a bit impersonal because they're not going to see them again. But if it's kind of an outpatient service, it could be a cardiology outpatient appointment, or it could be just a psychiatry outpatient. And language comes up quite a bit along the way. So that's my view.
Thank you. Just picking up on what you've both said, actually, and just bringing it back to GP shared care, looking at the physical health side of things. I think what's really interesting is we're all sort of picking up on, should this patient be part of a shared care model? Well, yes, in an ideal world, that would be great if that was their choice, of course. That would be great if they had some extra mental health support so that wonderful GPs can be looking at that physical health side of things as well. But in reality, can that always happen? I think what we're saying as well is maybe not. But I think just to take a moment to acknowledge as well, again, coming down to consumer agency and choice, that there are peer work models, and we have a couple of things in CESPN, like primary integrated care supports, where there's a peer worker and a mental health nurse so you're looking at two sides of things. So it's about thinking about other models in addition to shared care. But I just wanted to pick up on that point that's coming through. And with that, I'll hand over to you guys.
Hi, I'm a pharmacist for the Southern Adelaide Community Mental Health team, and We haven't really spoken about what's gone well, and I think that the fact that he's even getting the depot as regularly as he is a great thing. And I think part of the community mental health team, one of the challenges that we face daily is people getting their depots. So, and I also find it very interesting that the majority lived experience group feel that he's not acute enough to be part of a potential shared care model. Ideally, with resources being abundant, I would think that everyone should have a shared care model, even for yourself as the GP, to be able to ask questions. One of your examples was medication changes. I don't know what resources you would have besides, like, as in colleagues or people to ask in that specialised space as well, to be able to reach out. And I think that's where the hospital or the public kind of system can help. And I think the table was also speaking about what could be improved is that whether they had like a case manager or someone else that they're seeing outside of your time, because you're saying time is both a curse and a blessing. You're not seeing them very much. So having that person there with them if they need in times of crisis, when, you know, his dad's terminally ill, would be very helpful in these times, but he doesn't necessarily need to engage with the other team as much if he's already going to see you. But yeah, just wanted to add that.
Sorry, I just wanted to share a service that I used to work with in the UK. So I'm a UK mental health trained nurse. And I used to work in and manage what we called a link worker service. So we were out of the community mental health team. We were part of the wider services, but we actually worked in the GP surgeries. So we would provide a lot of that support. And some of those conversations were very simply corridor conversations just to give support to the GPs. But also when things were slightly escalating or there was concern in any way, we were able to engage with people without needing to put them under the umbrella of community mental health services. So we could see them in the GP surgeries. Nobody knew they were there to have any contact with mental health services. But when escalation was required, we could do that immediately. And there wasn't all the barriers of who to refer to and has it been missed or any of that. You know, we would follow everything up. And I work in South Australia, so I know what the system is like, and I've worked in the outer south as well as now Carlin. But it's a shame that we have such a fragmented system that what we're actually looking at is this. I might know this person, I might not, but he might not want to engage with mental health services because the likelihood of him actually being placed on a CTO or being detained or anything is much, much higher. But that doesn't mean he shouldn't have any support other than his GP. And that's a real shame. I think it's just too fragmented. But it was more a comment really than answering any of those questions. Sorry.
I think I'll thank you for that as well. I'll let Chris and Phoebe maybe comment, but I'll just finish up my part by saying, yeah, I have referred him for 291s and into various, I guess, under the community mental health banner, not necessarily for long-term, you know, ongoing care. Maybe like it would be ideal if it was like a once a year review just to touch base. But I think what you're describing would be wonderful because I'm very happy to see him once a fortnight, check his mental state, give him his depot, I give him a flu vax if it's time. You know, I opportunistically do bloods and STI screening for him and various other things. But yeah, I think just having that case manager or somebody that you could call on to be like, oh, things are starting to go a bit awry. Like what other supports can we get in for him? And then if he's more stable, then yeah.
Thank you. We are, I think, over time. So I think, did we have one question up the back I saw earlier? Was there someone up the back I might have missed? I'll go to you last, and then I think Chris and I will just wrap up with some of the PHN perspectives. But thank you all so much. Everyone's got fantastic input.
Yeah, I was just saying, you are the good part of it. You're the connection with him. It's very often when people coming in for their depot that 1 or 2 days prior, they start getting agitated near the end of that time. Very possibly if you could do a warm referral to one of the lived experience or peer groups around and just try and give him some more support that way. But you are the good thing that's working for him at the moment.
Thank you.
And that's really good.
Yeah, he's quite happy to come in to see me once a fortnight. No, I've asked him a few times, and I'll continue to keep asking him, would you like me to send you to this service or that service? Or, generally speaking. He loves movies. He loves horror movies, werewolves, lots of 80s TV shows and 80s movies and things like that. Yeah.
Thanks, everyone. Super quick. I just wrote a whole bunch of notes as people were talking because it was fantastic conversation. It's really good for us in regards to how we continue to work on the share care model, because I think there were a couple of really pertinent points. So with that last question is, in regards to this person being a good fit and what could share care potentially do, I think this table over here brought up a fantastic point and then others expanded on it. The barrier that we don't want a person's entry to getting that extra support, the fact that they need to be in crisis for that to be kickstarted. So I think everyone here would agree on that, and we need other options available apart from that. So I wholeheartedly agree on that one. I'd love to see, as people talk, elements of case management, assessment review, things around medication adherence and management, care coordination, particularly by virtue of a multidisciplinary team, would be fantastic. I mean, there's lots of issues just in that case study that care coordination would be fantastic for. One of the things from a PHM perspective, and CESPN are doing, and no other PHNs are looking into it, is the concept of integrated multidisciplinary mental health hubs who offer care at what is now seen as a level 4 and IR level 4 level of care. So traditionally that missing middle, to hesitate for another term, so people that in this case probably wouldn't be acute enough for admission back into community mental health support to kickstart the rest of those supports, but could still be provided by virtue of a multidisciplinary team. So you might have mental health nurses, you might have psychiatry support, you've got care coordination through a social worker, and you've got links to a GP as well. So people like Claire that are there ready and willing to provide support. So you've got many of the elements that you need. I still think that there needs to be connection though to to mental health. So we can't deny that. So that's the part that I've written down loud and clear that we probably need to sort out as part of our model and where there might be a barrier. So Phoebe, anything else from you?
I'm probably just echoing a bit what Chris said, but I think what we kind of were talking about going into this is that the shared care model looks at working with one sort of cohort of people within our community, people with severe and enduring mental health issues, and that can look different for different people. But I just like that Chris picked up on things like new models of multidisciplinary teams and other services that exist out there, because I think there's people who are, it's about consumer choice, and it might not be that I might not want to be connected with a mental health service, but are there other supports out there in the community? And that's something that I think I've really heard loud and clear when it comes to the GP shared care model being that particular barrier, but also just enhancing and emphasising the importance of other sort of models of care in community. So I think we'll wrap it up. I'm assuming afternoon tea is probably ready out there because we've gone a couple of minutes over, but thank you all so much. Really appreciate the participation, and have a great afternoon.
Like if you're concerned about his presentation while he's writing, that's what happens with my clients. Yeah, no, I just thought it's a good option to explore because then
the kind offer for a picture of us to be taken?
That'd be lovely. Thank you. I've got mine are in the back there. That's lovely of you. Thank you. I'm going to take my glasses off.
No.
No.
It's for when I'm.
No, because then you get photos like this. If you pronounce something weird, you get photos like this.
That is so true. You know what? It's candid. Action
Well,
shot.
deep in think, deep in thought. Why are we here?
Good afternoon, everyone. Can one of you... Good afternoon, everyone. Hi, all. It's we might make a start. It's just about 10 minutes past 4. Welcome to this session of lightning presentations. My name's Amanda Wheeler, and I'm chairing or facilitating the session. We've actually got one less presenter than we were expected because one of our presenters has been moved. So just so that you know, if you were trying to attend Justin Chapman's presentation, I'm not sure what order he will be in, but he's in the room next door. So he's in room 3. Otherwise, we have all of our other presenters here. And so what we're going to do, instead of trying to ask the presenters to stop early to allow for questions within their 10 minutes, I've suggested they have the whole 10 minutes for their presentation, and then we'll have a minute for questions after the end of each one, so that we can actually really, no one has to race through to the end, I'm hoping. Okay. So, and feel free, if you're going to other rooms, just quietly slip out when, that's fine, if you want to go and visit some of the others. So our first presenters today are Lisa Wilton and Mai Duong, and you've got their whole CVs or their little bios in your, I think, are available online. But just in summary, so Lisa is an advanced nurse consultant working in the South Australian Office of the Chief Psychiatrist, and Mai is a general practitioner and GP integration officer at the Southern Adelaide Local Health Network. Welcome, and we're looking forward to your presentation.
Thank you. going. So this is not us. This is a saying that we really like, resonates with us from Mental Health Foundation UK. You can't hear. Is that better? Yes, okay, all right. So we love this one, Mental Health Foundation from the UK. There is no health without mental health, no recovery without physical health. And of course we respect acknowledge the lands that we meet on today and acknowledge our lived experience. So, so this is our presentation around what we are trying to achieve. So we are trying to put together a mental health and shared care general practice, shared care model of care co-designed with lived experience, general practice and the mental health services, where we've got a team-based approach with shared vision and everyone being equal partners in this. And the model that provides clear expectations with guiding principles for all of us to aspire to is what we are after.
Thanks, Lisa. And then in this context, share care is really trying to address the fifth essential element in the Equally Well consensus statement that everybody knows by heart, I'm sure. So the fifth element is about care coordination and regional integration across health, mental health, and other services and sectors which enable a contributing life. So for the GPs in the room, this is really about how we collaborate together and work all together towards the same, outcomes and vision. It's sort of a bit different to things like the obstetric share care model that we have in SA, where you have to, do specific training and be accredited to be part of the thing. This is for all of the GPs. So for a person and their regular GP and then the mental health team that's involved in their care, how do we work together and how do we have a clear idea of who does what so there is no, doubling over of the things and no things that fall through the cracks, essentially. But before we delve into the model of care itself, we'll just quickly tell you about how this began.
So, yes. It's actually been a bit of a journey to getting here. So back in 2020, during COVID and the advent of Teams and Zoom, and we went, great, let's pull a group of people together who we can't get together, but we can all get together on Teams. So we pulled together a group with a focus on mental health, and we connected all the LHNs. At that time we connected DASA to the GP integration officers, which I learned about and was very fortunate to link with all of them, and all of them had a passion for mental health as well, which I was very fortunate around that as well. We had mental health service medical officers and a whole heap of clinicians and the PHNs, and we joined together and we aimed to find ways to facilitate mental health services and GPs working together to provide a holistic care and improving communication and ultimately outcomes for the people that we work with. So one of the first projects that we did was we collaborated and got together a mental health GP shared care webpage. We call it the one-stop shop for GPs, where it actually links to all mental health services within the state and or the state's mental health services and a few other bits on there. And so we got that off the ground, and then we thought, okay, well, let's provide some education. So we did a few focus groups. We pulled 4 focus groups together across regional and the metro areas, and we went jointly with GPs and mental health psychiatrists facilitating those workshops. And we were asked them their feedback or their identified priorities that lent themselves to educational opportunities. And then the second part of the focus group was around discussing questions that specifically related to shared care and educational needs. But what actually came out of that was that 3 out of 5 of the responses said that they wanted the development of a mental health and general practice shared care model. So that's what we set about doing. Thought it was going to be easy, didn't we, Mai?
Yep.
Yeah, no, it's not.
It takes 6 months.
18 months later, we're still here. So, so we did some joint funding of the sessions that was provided through the Adelaide Primary Health Network and the Mental Health Strategy and Planning Branch. And in as well as looking at how we were going to pull this model of care together, we'd started doing the education sessions as well. So in 2023, we actually held 3 GP mental health education sessions, and we did 5 echo sessions that had an equally well focus. So that was the whole component of the echoes. And we really acknowledge that the mental health services require the support of holistic, specialised general practice care for people to be able to manage well and wholly. And then in January 2024, after some great deal of planning, we pulled together a workshop for GPs, mental health services and lived experience, and we looked at pulling together what the start of the model would look like. And this was attended by some lived experience. We had 16 mental health clinicians, 5 GPs, PHNs and 8 other NGO and clinicians around there. During that year too, we held another 5 echo sessions and another 2 GP education sessions too. And we then spent lots of time collating the workshop information. We did it with post-it notes, so it took us forever. And then in May this year, we did another co-design workshop to test where we were at with all the information from the first model. We got a bit smart then and we used Mentimeter, so much easier to collate the information. And so in that one, in May, we had 7 lived experience people, 19 mental health clinicians, 10 GPs, another 5 clinicians in there. And we had made sure we had specific regional Women's and Children's Hospital and Aboriginal consultation for that, and so that we make sure that the model covers all of those aspects. So we've got further consultations planned, and in SA we have got the unique opportunity of working with the clinical prioritisation criteria team. So the CPCs are being done all over Australia at the moment, but the first team nationally to be mapping mental health processes is our team here in South Australia, and the model of care is actually going to be referenced as part of those CPCs. And of course, all of the foundation of the model are the 6 essential elements from Equally Well are part of that. And it fosters the provision of holistic health care, looking at identifying physical health needs through assessment, monitoring and addressing those, appropriate service referrals and education, opportunities for lifestyle support interventions. And it's hoping or envisaging that establishing the shared care partnerships will ensure that people of all ages, including the children and older persons, receive appropriate referrals and support for their physical health needs. And noting that the importance of preventative care, especially for children and young people too.
So the aims of the model of care. So basically, as Lisa said, we've gone through that whole sort of co-design, crowdsourcing content of the document. And so the document really aims to do a few things. There's like sort of a high-level section about why do we need to do this. Then there's a section around guiding principles that have really come up at the focus groups about what is important in a person's care when there's the person and the regular GP and the mental health services involved, really. And then there's a third part that really has sort of step-by-step practical guides that show what good collaboration looks like at the specific touch points of a person's journey. Often in my GP integration role, I'm being asked, but what do GPs want? And so it was great to have the forums and the focus groups so that, you know, does this model suit general practice? Does this model suit mental health services? Does this model suit people seeking care, and then how do we work together to achieve that? So it's really a blue. Oh, excellent! I'll go really fast then. So that's really a blueprint for what good collaboration looks like, and so each of the LHNs will implement it in the way that fits their services, but it's really trying to have that common share goal so that we don't dispersing efforts trying to replicate things that are a bit same but different. So those are like the big boxes that we're thinking of in terms of the patient journey, and we've mapped points of communication, and for guiding principles, we have like what are the expectations, how we go about this, how we evaluate this, and the long-term considerations as well. And then that's an example of the step-by-step practical guide for one of the steps I was identified before. So it's all based on the tools that we have now, like faxes, and then trying to make the most out of it.
And where we're going from here, of course, we need to consult more. We need to finish rewriting, and probably after consultation, rewriting, and then finally publish it. But what we really need to acknowledge is that all the mental health services and general practices have already got established individual processes around communication. And it's not about necessarily changing those, it's about building on those and doing what we can with what we've got, and then making sure we go a bit further. And recognising that while some LHNs have got established shared care and GP liaison positions with the teams, that's not the same practice across all of the LHNs, but it shouldn't be an impediment to actually establishing effective shared care communication and practice strategies. There we go.
Thank you. That was a whirlwind tour at the end. But that's all right.
1 minute?
That's fine.
God, I thought you said 5.
Does anyone have any questions for Lisa or Mai?
Great.
No? No? All right. So how much more time do you think this is going to take? Because you said at the beginning you thought it was all just going to be 6 months.
Yeah.
So how much more time, and what have you put aside now to actually get to the point where this project is completed before you might start evaluation phases?
So we're actually really close to getting it back out for consultation again, but we've recognised that we need to write a much more detailed executive summary. So once we get the executive summary out after Mad November is over, here in South Australia, then we are hoping that we'll actually get it out we'll do a soft consultation with all the people in the workshop and the people that have been involved in it along the way, and then once they've had a look at it, we'll do it again. But we actually have got a deadline. We have to have it finished by July.
Okay.
Next year.
So if you were working with someone else and they said, we want to do something similar, what kind of time frame would you now recommend to people that they're going to need if they were doing it, with your hindsight?
2 years? 3, maybe? No. It depends on how well you can get your collaborative groups together and how quick you can do that and how much support you actually can get, because Mai and I have taken the lead on this a lot, and so we are writing this on top of what is usual everyday work. So if you can get project support with it, it will probably take a lot less time. But if you're having to do it on top of, I would give yourselves a couple of years.
Okay. Did anyone else have any other? Yes.
Hi, Susie.
No, I just wanted to ask what the rollout plan will be once you get there. Like, what does it look like? I mean, there are a lot of GP practices around. Like, how do you get this information to everyone to get that consensus around what shared care needs to look like?
Well, we're really fortunate because part of our consultation team has been our deputy chair of the RACGP. So we're really hoping to lean on friendships there to get some of this out. But yeah, we will engage with comms as well. Once we've actually got the model, then SA Health Comms will actually help us with the communications plan, and we'll be popping it out through there. It's really important to have that good communications plan. We're partnered with the PHNs as well, so getting it out through the PHNs, and they've been with us all along the journey too.
Thank you. Sorry, I was just thinking about tea problems. Any other questions?
I might have missed it, but can you fit this in with my health record at all? Because my health record is so important in terms of communicating and using the same plan, maybe.
It is in our step processes, and the My Health record goes in there. I mean, we have got in the things that we've done, we've got our long-term considerations in there, because this will always be sort of like a working document as we go through, and as we know, we don't have secure messaging here in South Australia. So it's about what we've got now, and we've certainly got my health record in sights in the plan. But long term, we would love to have a shared record, which, you know, I'll be retired before that happens.
Thank you.
Thank you. Thank you.
No. So our second presenter today is Smonda Cock, and she is a mental health dietitian at Eastern Health in Victoria.
Hello everyone, my name is Smonda. I'm one of the dietitians, mental health dietitians with Eastern Health back in Melbourne. So today I'll just be presenting on my project on embedding dietetic support in the clozapine clinic to support metabolic health. I'm just going to mention that there has been a lot of talks around clozapine clinic today by Scott Clark. So yeah, his work has been really, really valuable as well. Firstly, I just want to acknowledge country and acknowledge lived experience as well. But I'm just going to cruise past this as it already has been done. Well, so back in April 2024, there was an opportunity that arose. So a clozapine clinic was introduced to Eastern Health. And clozapine clinic is targeted for consumers who have lived experience of schizophrenia, schizoaffective disorder, who are prescribed on clozapine. So they're stable, no need for case management. And I thought, hey, what we have known so far about clozapine medication itself, there are increased risk of people developing metabolic syndromes, such as diabetes, heart conditions. And so I thought maybe a dietetic service would be valuable in this area. So what I've done was I've done some benchmarking. I reached out to 10 different public healthcare services and reached out whether they have a dietetic service embedded in their mental health services. So what I found out is that 7 out of 10 health services have a mental health dietitian embedded in their community. 4 out of 10 public health service has a clozapine clinic or clozapine program. But I was wondering whether there was a dietetic service embedded in those clozapine program. Unfortunately, there's none. And we happen to be the very first one to test this out, whether this is valuable, and to have a dietetic service embedded in the clozapine program. So what I've done is I looked at referral reasons. So what I mainly manage is metabolic syndrome, people coming in with type 2 diabetes diagnosis, or who has high cholesterol, who are at increased risk of heart diseases. Increased appetite as well, because we do know that clozapine, the medication, has side effects such as a lot of weight gain and increased appetite. Gut side effects as well, constipation and clozapine. Constipation is very common. And also food security, so education around cooking skills, meal prepping, budget meal planning, and grocery shopping. So what I've done is I have provided a dietetic service every Wednesday and offered this service to people who are managed under the clozapine program. And this is free of charge, and usually I get the referrals from the psychiatrist or the nursing staff. So my aim was to establish this service and evaluate it. So the clozapine clinic started in April 2024. The dietetic service started in June 2024. And hopefully in 1 year, what we hope is to manage around 20% of people who are prescribed on clozapine as part of the program. So what I was hoping to measure is their health measurement, their overall well-being, their cardiometabolic biomarkers as well. So why does this matter? So as part of the Equally Well framework, one of the focus area was improving metabolic health, weight and diet. This was back in 2019. So a lot of people with mental illness face high cardiometabolic risk. And as dietitians, we play a huge role in advocating their physical health. So the things that I've done with consumers who come and see me, I focus on healthy eating on a budget, portion awareness and appetite management, eating for heart health, supporting or eating to support blood sugar levels, and choosing healthier snacks. These are all educations that I provide for consumers. But I also do provide practical activities as well, such as supermarket tours, applying skills in real-life settings, and also providing exercise recommendation as part of the Australian Physical Activity and Exercise Guidelines. So what did I measure? I measured their body weight, BMI, waist circumference, the lipid profiles, HbA1c, and their bowel action. I also measured their habits and their behavioural outcomes as well, so whether they're receptive of their nutrition education. And also the consumer experience as well, so getting the feedback on how valuable this service was to them, and also their satisfaction in the care, and also what the staff thought about this service being embedded in the clozapine program. So this is the outcome that I've seen in the past year. So before they came to see a dietitian, what I've noticed that there was an average of 18 kilo weight gain within 3 to 12 months among the consumers that I was seeing. But with the dietetic support, what I've seen was there was 1.4 to 16 kilo weight reduction within the 6 to 12 months they were seeing me. There was 3 to 6 centimeters reduced waist circumference and greater nutrition engagement and lifestyle change. With their metabolic biomarkers, their cholesterol has improved. Before they came to see me, the cholesterol was above the range, now gone down to 3.7 to 4.3 within 6 months. HbA1c was stabilized or improved. And I got a lot of people who came to see me with bowel problems as well. Constipation, very common. They were opening once a week, now to every 1 to 2 days, which was amazing. In terms of the experience themselves, one of the things was access. We spoke a lot today on access, actually, how access is such a huge problem for a lot of consumers who asking to improve their physical health. So one of the feedback that I got from a lot of the consumers is that having a dietetic service embedded in clozapine clinic, this integrated approach, really gives them a lot of reassurance, because seeing a dietitian can be very confronting as well, to acknowledging that, yeah, physical health is also an issue on top of their mental health as well. Another thing was that it's free of charge. I got so many people, before they booked an appointment with me, they were like, how much does it cost? Do I have to pay? And I was like, no, it's all free of charge. And they were like, dietitians that I've seen in the past are expensive. I'm glad that I don't have to pay. They valued the support as well, because of their improved nutrition, bowel movements. Their quality of life has also improved alongside that. In terms of staff was very, very appreciative and very grateful. One of the quotes was, the familiar clinic setting and integrated approach was beneficial, especially for clozapine-related cardiometabolic health. So what worked well? Improved access and engagement for high-risk population. The fact that it's an integrated model, having a dietitian embedded in this clozapine program. And to improve access to healthy diet and promoting physical activity and their mental health as well. What I really hope for the future is that seeing the success that in the past year that I've worked with consumers, I really do hope that there will be dietitians and dietetic services embedded in many community health services. Clozapine clinic is one thing, but also community care teams as well, which is a huge thing. Yeah, so that's pretty much it for me today. Thank you so much.
Thank you, Smonda. That was great. Anyone have any questions for Smonda?
Yeah, just a quick question. So I worked in community public service mental health teams, and there's sort of this little bit of attitude that, you know, you wouldn't get consumers to engage. They wouldn't do it. So I'm kind of interested whether the kind of expectations that you noticed from staff, whether some of those changed during the course of what you were doing as consumers did actually engage.
Absolutely. This is one of the common issues that we actually have seen. We have given all of our consumers a choice to see a dietitian, whether they want to be referred to a dietitian. And so often so when they do see the psychiatrist for their clozapine review, I'm next door. So it's either whether it's an introduction, hey, do you want to meet the dietitian? It wouldn't be a consult, it would just be to say hi. And here's some information. If you're interested, next month when you come back for a clozapine review, how do you feel about booking in to see a dietitian? So it's always about more exposure and just seeing what a dietitian could do. But also they do get their bloods done every 6 months to check their cardiometabolic health. If they have seen that their cholesterol, their blood sugar levels has gone worse, there's always a dietitian next door that you can talk to about these things as well, if they are comfortable. Yeah.
Michael Tam, I'm a GP. Look, thanks for that. Really, really interesting. This is, I suppose, a sort of content type question. Anecdotally, at our service, we've sort of noticed quite a few people where one of the drivers for ill health was their consumption of sugar-sweetened beverages.
Yeah.
Have you noticed that in your own service?
100%. 100%. I get a lot of consumers who come and see me telling me that they do not like the taste of water at all. Oh, how many times has everybody heard that? Even ourselves, we experience this ourselves as well. But what I do recommend is the sugar-free cordial, maybe flavoured water, adding some fruits into the water to make it flavourful. But most of the time, I start with diet cordial first. But sometimes people think that that's just not realistic enough. They still want to stick with their fizzy sugar beverage, trialing the sugar-free soft drinks. So it's just working alongside with them. The fantastic thing about this service as well, it's everything that I do is all patient-centered, tailored to the consumer themselves, because everybody's on their own journey, and everybody is different as well. Yeah, so something like that is what I would do. Yeah.
So I work in the clozapine service as well, and I think you're doing a really great job.
Oh, thank you.
It occurred to me recently, you know how people get the urge to eat because of the medication. Have you found a strategy to explain that to consumers? Because I think we've missed that a bit in our education, and because once we know something and understand it, it's easier to perhaps make a change.
Yeah, absolutely. A lot of the times, you'll be quite surprised because I do a whole dietary assessment, seeing what they usually eat every day in 7 days. And what I often find is that a lot of people do tend to skip meals, and people who are living with schizophrenia and schizoaffective disorder, they don't have a usual day pattern where they wake up at 8 a.m. and sleep at 10 p.m. You'll often find people waking up at 2 p.m. and sleeping at 12 a.m. and they find themselves eating and snacking in the middle of the night, which is like 1 a.m. or something like that. And a lot of times they usually have 1 or 2 meals a day, and usually it's about education around how often do you eat during the day, and what the portion size, what does that look like? So we encourage at least 6 meals a day, small meals, portion size, and it's about choosing foods that are high in fiber, high in protein that will keep them fuller for longer as well. So it's around the education in that helps them manage their appetite better. Yeah. Yeah. You're not full. It's a satiety. Yeah, absolutely. Unfortunately, that also has to be a conversation with the psychiatrist as well, because the side effects from the medication, it's hard to control that side of the appetite. But when it comes to, but it's also practicing mindfulness as well. What does it feel when you are feeling full? And so myself, and we got my colleague here, Lucy, we do practice mindful eating with consumers. We do groups as well. And so we would give them a piece of mandarin that is so citrus, is sitting with the food, eating it, determining the taste, the texture, But also, how does it feel in your stomach? Has that changed your appetite? If it hasn't and you're still hungry, have one more. And keep on being mindful of how you're feeling. Yeah. No worries. Thank you so much.
And we have, to follow Smonda, we have her colleague, Lucy. If I can make this work. Right. That one?
No, underneath.
Oh,
There we go.
that one is out of order. I drive a Mac. I don't drive a Microsoft. Thanks, Lucy.
Hi everyone, my name's Lucy and I'm a dietitian working in Eastern Health across primarily our community and our inpatient settings, and I'm presenting some work I've been doing on understanding consumers' perspectives of food service systems in mental health inpatient units. I'd like to start with an acknowledgement of country and an acknowledgement of lived experience. And so I guess where I was starting off is what we know and what we don't know. So in the hospital I work at and with a lot of other major hospitals, our current food service systems are designed for medical wards. They're designed for our consumers in physical health settings and may not meet the unique needs of our consumers. So our consumers are at an increased nutritional risk, but it's different than what we're used to seeing in our physical health wards. So maybe due to the side effects of their mental illness, so appetite changes, food refusal, disordered eating behaviours. Also medication side effects is a massive one as well. Weight gain, metabolic changes, altered taste or appetite. And there is some research that has been done that's showing that in our mental health inpatient units, our consumers aren't actually meeting their nutritional needs. In this research showed weren't consistently meeting their energy or protein targets. The role of hospital food service system is to support nutrition as best we can. And guess what I was thinking about as a dietitian working, starting a new service in an inpatient unit, was that I thought that a food service system was a really good opportunity to positively influence wellbeing by modelling and supporting healthy eating or modelling food behaviours. But that can only really be done when the systems are accessible and tailored to the needs of our consumers. So I guess that led to my key question was, how are the consumers perceiving food service systems and its role in supporting nutrition during their admission? So my aim was to evaluate whether the current food service model was meeting the consumer's needs and seeing how they viewed its role in supporting their physical health whilst they were in hospital. So I was wanting to engage key stakeholders, so the consumers themselves, food service staff, health professionals, also understanding the stakeholders' experiences of the system, and also wanting to inform future recommendations for service improvement. So basically how I got my data was at about 6 months, every time I had an interaction with someone on the ward, I asked them how they found the food service experience. And I kind of went over everything from about, how was it ordering meals? How is the dining environment? Just anything that encompassed what their experience with food was like in hospital. And not only did I do that with one-on-one sessions with consumers, we also have community groups and nutrition groups on the ward that I would get that information from. So basically, any time someone saw me, I was asking them the questions about how they found the food, which often got me some very interesting responses. So I guess I then completed a qualitative analysis and I got 6 key themes. So the 6 key themes were meal selection, food satisfaction, variety, dining environment, limitations in the food service systems and provision of additional food. The main one that I found was that overall the consumers were not being adequately supported to engage with the food service system. The number one thing I found is hospital menus are really confusing. They start with lunch and then it goes lunch, breakfast, dinner, doesn't make a whole lot of sense. And they may not, for some of our consumers who are quite unwell, that can be really confusing to understand. And hospital meals, they're bland and repetitive. They're designed for people who are in hospital who are physically unwell. The variety, I would say, especially, our hospital has a 28-day cycle, but even within that 28-day cycle of meals, there's a roast on every day. And it's like, you might get a roast and a pasta, or a roast and a curry, and it can be really repetitive to get that twice a day for however long you're in hospital. The dining environment, some people found the dining environment really lovely, that it was communal and people could, chat over a meal. Others find that really quite overwhelming and overstimulating. I had some consumers who would much prefer dining in their room, or they, even they didn't think they were allowed to, so they just missed a meal rather than going out to get their tray. Limitations in food service systems. Hospital food service have a really hard job. They've got to try and meet the nutritional needs for everyone who's come into hospital for a variety of different reasons. So, not only our medical needs for our diet, also our personal preferences. So it's a really hard job to try and cover all of that. And then finally, this is the provisional of additional food. So on our ward, we're lucky to have sandwiches, yogurts, fruits, things available on the ward, but sometimes that's just not enough. And especially if you do have, if you're vegan or vegetarian, that limits your options even further. So there was quite a high reliance on external food sources, so Uber Eats, DoorDash, family, and that puts an extra burden on the consumers and their families when, if you look at in Victoria, our food service standards say that we should be providing all of the nutrition that they need whilst they're in hospital. But people are having to rely on external sources because they're not meeting their needs whilst in hospital. So I guess I then kind of grouped things into about 3 different groups. So the first one was value, autonomy, choice and behaviour modelling. So I think offering meal choice supports patient autonomy, which is a core principle in mental health recovery. I can think as a clinician how much, when I would go and actually sit down and complete a menu with someone, the benefit that could have. And if someone hasn't been completing their menus for 4 days and finally they get a choice of a meal, like that, I can't quantify what that does for someone, but I know it makes them feel a lot better. They're finally not having roast for dinner. They get to have cannelloni or something, offering them that choice. A food service system, I think, is a really practical environment to help model and practice healthy food behaviour. So portion sizes, showing someone what a balanced plate can look like. On our ward, we're lucky, we have fruit available on the ward. So it's a really good opportunity for us to model and support those positive food behaviours whilst they're in hospital. Also, addressing the physical health gap. So variety and accommodating individual dietary preferences is critical for meeting diverse nutritional needs and mitigating physical health risks. Everyone is different, and so it's a really hard job to try and manage all that, but we have to try and do our best to manage all those things. Aligning food service with patient needs reinforces that physical health is integral to mental recovery, that one will not work, both need to work together. And then access and stability. So access to supplementary food addresses low appetite or increased needs. So if some people doesn't want a main meal, we can offer them a sandwich. Rather than them not missing a meal because they don't want to have the main, we have something else they can have. It also supports optimal nutrition to help model regular structured eating. I've had so many consumers who aren't eating well coming into hospital, just the knowledge they've got breakfast, lunch and dinner, and they know what time it's going to arrive, helps them really structure their eating and help model that behaviour. And then finally, so therapeutic environments and outcomes. So I think a flexible dining environment is really important, so it helps reduce stigma and encourage social engagement, which research does show that when you eat with other people, especially if you're at risk of not eating very well, improves oral intake and patient satisfaction. So just being able to share a meal with someone, that's why I love being a dietitian, that food's not just about the food that we put in, it's the social, it's everything about food. When we get to dine with other people, that really heightens that. And then so client-centred design. So co-designing food service systems with consumers and using their feedback is crucial. This will improve therapeutic outcomes by consistently meeting the needs, basic physical health needs to support comprehensive recovery. So I guess my conclusion is that I identified 6 key themes, and the 3 things I pulled out of that was a tailored food service system can enhance satisfaction and support recovery. Co-designing this with consumers is essential to ensure responsiveness to diverse needs, and an improved food service system can promote both nutritional health and mental well-being. And where am I going to now? I've done a lot. I've now figured out. I joke this is like I opened a can of worms. I had to try and figure out where to go with it now. So I'm continuing to share findings with our key stakeholders and using it to guide future research and service improvements. The two things I'm really keen on, exploring how to increase menu completion. I think it's one of the easiest things we can do to increase satisfaction is make sure people are regularly selecting their meals, and the way they do that is being accessible. And how we model positive food environments, behaviours and attitudes. Long term, we want to, we're doing menu audits and meal satisfaction to understand, see if our interventions are working, with a longer term vision to enhance food quality and sustainability. And this work will align with the Equally Well framework and help move us toward maybe some tailored mental health food service recommendations like they have in New South Wales. They've got the nutrient gold standards, which actually provide tailored recommendations for mental health services. Yeah. And that's what I've been working on.
Thank you, Lucy. I think it's two really interesting presentations around a different allied health service and the importance of thinking about food beyond just something to sustain us, but actually the importance in our lives food plays. Does anyone have any questions for Lucy?
Thank you. Thanks, Lucy. That's excellent work. How do the staff in the units come across? How do they accept the influence of the dietitian then to trying to create a healthy lifestyle for?
I would say I've been really lucky that the units we've been working on, they've been so great of accepting our interventions. I think because they probably, before I started, we had no dietitian in our units, so they probably were, having someone there to help model that behaviour has been really well accepted. Yeah.
That's excellent.
Well, thank you, Lucy. That's great that you've got that perspective. I just want to put a plug in for something in Queensland we've done recently, been done recently in Wide Bay and Harvey Bay. We've actually got an in-house chef in the acute unit who works with the dietitian, and people get to talk about what food they like and what they want to have, and the chef will make it for them. It sounds like a private hospital, which is, by the way, food in private hospitals are usually terrible, all right, because they think about cost, not about nutrition. So I just wonder if there's any flexibility, in what we do, because we're very locked into the hospital delivery hot box service. And in fact, this service is not much more expensive and one hell of a lot better. And they said that the rate of incidence, the happiness in the unit, one of the most amazing things I've ever seen. So fantastic around actually responding to people's interest and desire to have good food. So fantastic. So thank you.
Food makes us really happy. Food is one of those fantastic joys in life. And I think it's, remiss that we don't get to acknowledge all that even when we're in hospital. That's why I became a dietitian. I just love talking about food. It's my favourite thing. And I love being able to help, I joke, I think I've made up my job, that I get paid to talk about food every day. It feels like a made up job.
Lucy, I just love the attitude of curiosity and approaching your work and thinking about it. I think it's a fantastic way to approach your work. But I was wondering if there's any ideas that have been zero cost that have come out of this work that you've been able to implement. Maybe not, but I just thought maybe some ideas that you've just been able to do straight away at zero cost that's made a difference.
The ideas have happened not because of me, but it's been really good timing. So at our organisation, we're actually changing our food service model, the system we use. It's actually going to allow us to use devices to order food. So we're getting rid of paper menus. And so there'll be a QR code that consumers can scan and actually pick their own meals. That wasn't me doing that. That's just really serendipitous timing. But I think, even just things that I can do is just when I'm on the wards, just, offering to assist with, offering to assist with menus, offering to, if people got really specific dietary recommendations, letting the kitchen know. So it's probably more what I've been able to do as a dietitian, just be that person on the ward for them to, if people have any concerns about their food, to be able to help them with that. But I'm really excited for people having their own device to order meals. That's going to be really, really helpful.
Yeah, thanks for the talk, Lucy. I'm glad, John, you mentioned it first, because I was thinking exactly the same thing. I'm old enough to remember when hospitals had their own kitchens. Food was all cooked on site and staff would have the food that patients were having as well. I wonder whether or not we're just rediscovering that there is something more to food services exactly, other than just the provision of nutrients?
Yeah, so I've worked, so at Eastern Health we use a central production kitchen, but I've also worked at other services where it has been cooked on site, and you can definitely see a difference in the flexibility of the service and how they can respond to different people when we have those kitchens on site, or even just, having a smaller kitchen that can provide additional things. Like I say, our ward, like we can make toasties on the ward, and that is like game changing. Like the fact that we can have toasty, even just the addition of toasties makes a world of difference.
Thanks, Lucy. Really interesting. I'd like to introduce our fourth speaker now, Stephen Hutchinson, who's actually not doing a duo act, he's doing a solo act. His colleague is not well. Stephen is a nurse consultant with the South Australian Prison Health Service.
So welcome to our South Australian Prison Health Service presentation, Mindfulness Self-Management Resources to Reduce Anxiety and Depression in People in Custody. And for Jack, my co-presenter, she's sick today, so solo. Of course, I want to acknowledge country, but I guess more importantly, I really want to talk about the over-representation of Aboriginal people in custody. 32% of people of Aboriginal descent are in custody in South Australian prisons. That's, in Australia, less than 3% of the population. And I was working around with the general manager at Port Augusta Prison and with some Uni SA staff, and over 80% were Aboriginal, and sometimes up to 60% in the women's prison. So we've really very much, and I've got some Port Augusta colleagues here, we're very much in the health space trying to close that gap. So South Australian Prison Service, known as SAFS, is a Central Adelaide Local Health Network statewide service that operates the health services across 6 sites. In the metropolitan area, we have the Adelaide Women's Prison and Pre-Release Centre and Yatala Labour Prison. Our regional prison sites are Mobilong Prison near Murray Bridge, Cadell Training Centre in the Riverland, Port Augusta Prison and Port Lincoln Prison. SAFS also supports 2 privately managed prisons, the Adelaide Remand Centre, which is operated by Serco, and also Mount Gambier Prison, operated by G4S. So mental health is a leading condition in our prison population, with anxiety and depression a significant concern amongst people in custody. In the prison setting, there's an inadequate access to mental health supports for people in custody, and prisoners don't have access to resources such as Beyond Blue, Black Dog Institute, Headspace, or any mindfulness programs. And we don't have access to Medicare's mental health treatment plans for GPs, mental health nurses, and psychology reviews. So untreated mental illness not only affects psychological well-being, but also contributes to poorer physical health outcomes, such as sleep disturbance, chronic disease, and substance misuse, which is further compounded with health inequalities in this population. Our mental health link portfolio nurses identified treatment for low to mild levels of anxiety and depression as a gap in care, particularly in the high security prisons where there is limited access to people, a lack of therapeutic space and time, and resource constraints. Our literature review identified minimal resources for self-directed management. This was a catalyst for thinking about how we can assist our prisoner patients. Since 2004, and I started in prison health casually in 2005, there have been an increase in prisoner numbers, and this is due to a number of factors. The 2004 Mulligan inquiry, a political focus on crime, developments in DNA, and an increase in our population. The aim of the research project was to evaluate the effectiveness of providing self-management workbooks with some brief education to prisoners who self-report symptoms of anxiety and depression. Ethics approval for the study was obtained prior to undertaking this study, and all participants were voluntary. The intervention of the workbooks was assessed with pre-workbooks and post-workbook evaluations of individuals using the Depression Anxiety Stress Score 21 and the Hospital Anxiety and Depression Score HADS. Pre- and post-workbook evaluations with the validated tools was conducted by the nursing staff at each site. A data analysis was undertaken using descriptive statistics. Participants included individuals from 7 prison locations across South Australia. A total of 89 prisoners participated in the study, with 11 participants identifying as Aboriginal or Torres Strait Islander. 89 participants consented to be involved in the project, with 76 completing the first 2 workbooks and 49 prisoners completing all 5 workbooks during their incarceration. In the study, 27 participants identified as female and 62 as male. All prisoners involved in the study received and completed at least workbook 1 and 2. The research project involved a UniSA social worker student originally, the Aboriginal Grannies Group, and the South Australian Literacy Council. The input included oversight to develop workbook content for self-management of symptoms associated with mild anxiety and depression for use at any time the individual experienced stress during their incarceration. They also provided assistance with ensuring the literacy and layout design were appropriate for all participants undertaking the study. So these are the workbooks. So workbook 1 focus on, so remembering they don't have access to internet. So the workbooks are mindfulness activities. And so the workbook 1 focuses on mindfulness, anxiety, stress, mood. Workbook 2 focuses on depression, hopelessness, dealing with grief and loss, a sleep diary, relaxed breathing and reflection. Workbook 3 involved drugs in prison, addiction, tolerance, dependence and withdrawal, coping with cravings, urges and reflection. Workbook 4 was emotional regulation, communication, dealing with anger and aggression, conflict resolution and reflection. Workbook 5 is something that I need to do, is exercise and healthy eating, resilience, goal planning and setting, and reflection. This research marked a significant milestone as SAF's first independently led study, demonstrating strong ethical safeguards within a comprehensive distress protocol in place throughout the project. Importantly, no participant required the protocol and no emotional distress was recorded. This indicated as an effective intervention design, and the study did not account for concurrent stresses that participants may have experienced during the research period, including court proceedings, relationship breakdowns, financial difficulties or prison transfers and cell relocations. These uncontrolled variables may have influenced participant engagement with workbooks and evaluation responses, suggesting that future research should incorporate life's events screening to better understand factors affecting intervention outcomes in custodial settings. The tables indicate that the tools utilised decrease the baseline levels of anxiety and depression when engaging in self-directed symptoms and care management using the SAF's wellbeing workbooks. The study found the use of the self-guided workbooks improved the overall post-wellbeing scores amongst the prison population. The results of the study showed that no prisoner experiences the same level of anxiety or depression prior to the provision of the intervention workbooks, and that regardless of whether the individual undertook 2 workbooks or all 5, there was a downward trend in all symptoms of anxiety, depression and stress. Research of this nature has not been undertaken within the South Australian prison health environment before, and the research demonstrated an improved outcome of all prisoners experiencing low, mild anxiety and depression. The workbooks were beneficial in reducing participants' anxiety and depression and assisted with open discussion around expressing their thoughts, emotions when returning to complete the assessments with nursing staff at periodic times. The resources have a lot of mindfulness activities, including tapping into self-awareness and focusing on mindfulness, which is strongly correlated with greater well-being and perceived health. This approach effectively supports people in custody to manage mental and physical health through self-awareness, behavioural change and skilled development. The workbook integrated exercise, sleep, nutrition, emotional well-being and acute service and encouraged early intervention. The workbooks have been recognised as an effective strategy to improve symptoms of depression with anxiety amongst the prisoner population. By integrating these workbooks into correctional environments, we've learnt we can empower people in custody to take an active role in managing their mental health, which is crucial for rehabilitation, self-esteem and developing resilience. Several case studies have highlighted the positive benefits of the wellbeing program to reduce the participants' anxiety and depression. And the last couple of slides is for people in custody identified as requiring further support, we referred them to our nursing staff trained in trauma-informed care and behavioural activation. And Tony, just sitting here, was one of the people who led behavioural activation, which was a collaboration research feasibility study with the University of South Australia. And very much appreciate Tony and the amazing success that feasibility study had as well too. This is a preventative and early intervention treatment rehabilitation model for depression. We wish to acknowledge and extend our sincere appreciation to all participants and healthcare professionals who contributed to this study, conducted within the custodial environment, and their engagement, insights and collaboration were invaluable to the success of this wellbeing program. Thank you. Can I run away now? I'd like to run away now.
No, first of all, I'd like to say congratulations to you and your team for conducting a research project like that in a really difficult environment, but and achieving what you've achieved. So
we're only a small team compared to other states and jurisdictions, and I think we often punch above our weight. We can swiftly try and progress through the bureaucracy and make an impact. And I think with the wellbeing program and the behavioural activation, we've had a lot of success, and people uptaking that from other jurisdictions. SAPOL has been very interested, New South Wales Justice, Forensic Health,
Well done. Does anyone have any questions for Stephen? At the back, so you don't get to run away yet.
Hi, I've just got one question about literacy. Did you find any challenges or any barriers in regards to the literacy skills of prisoners in providing them with the workbooks?
Yeah, there's literacy. A lot of our people in custody can't read or write. So the nurses have a good relationship and rapport with our people in custody. So in those instances, they would have them in the clinics and sit down with them and actually go through the activities and explain what was required for each activity and assist them.
Any other questions for Stephen? One down here.
Really great piece of work. I was just wondering where the workbooks came from. Was that something you guys developed internally?
So we looked worldwide with the literature review, and there was not much out there except the United Kingdom, which I had a privilege of touring 15 prisons over there in 2023. And they had a very small anxiety workbook, and we actually based it on that and obviously expanded it. So thank you to the UK for initiating this. And so, yeah, that's where it came from.
I've got a few last words, so I'm just wondering that in terms of how the workbooks were used, and then you might have covered this, were they done in groups or was it all self-directed
So it was initial consultation with our nursing staff. The nursing staff would sit down in the nurses' clinic with them and go through some of the activities and explain the workbook. We'd also do an assessment to make sure that there was no acute self-harm or suicide first, and then we would stop and refer them to our acute care. But it's sitting down and then getting them back at intervals and seeing how they're going, whether they needed further help. But it was self-directed in the divisions and in their cells. And I think that also contributed to others seeing what their cellmate was doing and helping each other.
Thank you. I'm going to have to, I know we've got a couple more questions, but can you catch up with Stephen afterwards? Thank you. And now we welcome back Lisa, who's going to talk again on behalf of her large team.
Yes, my large team, all of me, yeah. No, wrong one up.
Is your one there?
One, yeah, wrong presentation.
Wrong presentation?
Yeah. I can't do this. Okay, well, let's try and do it together. So let's end the show. Go to end. Yeah, go end show. Is there an end show? Yeah, end show. Yeah. I'll let you. Which one is it? It is Empowering Recovery, that one. Yeah. Thank you. Okay, thanks. Now, I know how fast this 10 minutes goes, so I'm going to be speeding through this one because notice when we get the 1 minute, everyone goes, me included. All right. So our acknowledgements are done. So I wasn't actually supposed to be doing this one. Samana, I'd like to acknowledge Dr. Samana Thompson and the rest of the PhysiCard team. Samana's actually presenting down at SMHR, so I was the last one standing. So we actually originally had some conversations with Jade Riddell around the Flourish PhysiCards. To look at joining the New South Wales random control trial as a South Australian arm, but we were too late. We missed it by that much. So our next step was to consider what it looked like for us here in South Australia and where we could potentially get the best data and have the most impact on using the PhysiCards for improved physical health of our consumer groups. So we needed to convince the rehab team of the plan to use PhysiCards in a care and co-design study around their use. And fortunately, I have fairly good relationships with most of the team managers, so it wasn't too hard to twist his arm. So we have got some really great people who are keen to give it a go. So I was happy with that. Now this is actually the New South Wales trial paper, which was published in October, and what it actually showed is that the participants who utilised the Flourish PhysiCards were significantly more likely to identify that they wanted support for a physical health concern. So that was reassuring. So what we did, once we'd sold the plan and pulled the team together in the Callan rehab team,
Our southern colleagues at the Trevor Parry Centre, they were happy to be our treatment as usual cohort, and the director of our Wandaka, which is another community rehab in the north, has agreed to be our control group. So the project team's a multi-D team consisting of lived experience peer specialists, nursing, allied health, social work, OT, medical and academic researchers. And having Sumana, who's a consultant psychiatrist involved, has been brilliant because she's actually currently doing her PhD in health literacy, and that's really helped to shape the project. So we did this great brainstorm activity, which probably posed more questions than not, but it actually gave us a lot of really rich ideas too. And it was a really good time because it was very beneficial for allaying some of the staff's trepidation regarding scope of practice. So they thought that if we were introducing a PhysiCard assessment, that it was going to take away from their nursing assessment. So we were able to work through that. And we were able to clarify the current practices that occurred in the service that wouldn't be replaced, but hopefully enhanced. Well, that's our hope anyway. So it was important when we're considering our design to look at the importance of health literacy to be an integral component, and we looked at the WHO Charter for health promotion, of which health literacy is a key component of that. So when our goal is to determine whether integrating the PhysiCards into the routine physical health screening improves a person's outcomes of quality of life and their functional status. And we wanted to ensure that the residents of the community rehab centre were actually involved in the design process as much as possible, right from the flyer design and testing the PhysiCards. We needed to look at time to administer in relation to their admission processes and what that actually looked like around that, and for people who've already been in the residential community, and what the location of the activity was too. So we also road tested some health literacy tools with the staff to select the ones that we thought that were both comfortable, that we were comfortable with, and those that we thought had the best accessibility for the residents. And we needed to question if we were doing a quality improvement project or whether we were doing a research project that then required ethics. And it was important that we actually had executive sponsorship as well. So we had to do a briefing paper, and fortunately our Cowland Projects Board committee gave it approval. So now we report every 2 months, and our report notes for our team notes actually just is what we use to report up. Teams is used for all of our documentation, and we've made sure that the project aligns with all of the Equally Well consensus as well. And evaluating the health reflection tool with the study aims to provide evidence for a tool to improve physical health and well-being for people with a living experience of serious mental illness. And we hope that if it goes well, that it can be adopted in other areas. So there was things that we can do while we were waiting for the ethics question to be answered. So we looked at the measures that we would use along with the general physical health parameters, and we looked at the two health literacy tools. And the ones we chose were the Realm and the newest vital signs, along with all of our other standard measurement techniques that we use. So this is the rapid estimate of adult literacy in medicine. It's we call the Realm. And this is to make sure that we provide the best education information for a person, and what they have to do on this is they actually read the list, and it's scored for the questions or the words that they can't pronounce. Then there's the newest vital signs literacy, where they actually look at a person's ability to read a label and decipher that information. And both of the Realm and the newest are well-respected and tested health literacy tools. We're also looking at using the goal attainment scaling, or the GAS, and that's to record each person's identified health goals. And noting that in the early design phase, when we were doing this and testing the PhysiCards, some of the residents only identified one issue that they wanted to work on, and that posed quite a dilemma for the staff. They were going, well, surely they've got more, you know, they've got diabetes and they, you know, all of these other things, but they only want to work on one thing, and we went, one's better than none. And it's very much working in a person-centred approach, so one goal that the person can focus on provides a really good basis to start from, and our view, as I said, is one's better than none. And it's also a way that they can test the water, and it might be all that the person can manage at that point in time. And of course we're going to work with what we're given. So while we sprang out of the gates with enthusiasm, it seems to be a bit of my I don't know, wishful thinking here. There's lots of things that slowed our progress. It's a bit like the good news, bad news in our children's books. So the realm posed as a question, can we alter 2 words? There's 2 words on the realm that we just don't feel are appropriate. We feel that they're quite triggering. So can we change that? And that's a whole project in itself. So for purposes of that, we're actually trying to gain permission to do that. The second hurdle was that our project now actually requires ethics, but that's not a problem because everybody loves writing ethics. No, they don't. So while the delays are part of the course, they are necessary. And so while we are still moving forward, we are moving forward at a lot slower pace than what we actually thought we would be. The poster or the flyer is co-designed with the Elpida residents, and that's undergoing changes in response to their feedback. And the last round was, it's just still way too busy, and what we really want is somebody to actually explain the project to us, so that will be happening in the community teams. And then when they tested the Fizzy cards, the first time they tested it was in the treatment room, and there was just no room for it. There was nowhere they could do that, so we've moved on to an activity room instead for that. And the activity takes about 20 minutes. So while we're waiting to get the ethics done, we're still able to do a lot more learning along the way and hopefully create the project so that we can refine the processes as we go, so that once we get that ethics, we'll be able to hit the ground running. And we just hope that that will be a positive thing. So, of course, the plan is get the ethics approval, refine it, collaborate with our other areas, do lots of PDSAs, and hopefully, if it works well, use a step wedge approach for the other areas. Oh my God, 10 minutes. So you just need a practice run.
Thank you, Lisa. That was fantastic. In the interest of time, we won't take any
questions.
Yes. If that's okay. Because we have 2 speakers to go, and Claire James is our next speaker. I'm just going to ask them to move the slide for us. Thank you. So just while we're doing that, so Claire is a hospital pharmacist and working in South Australia.
Yep. Medication optimisation. Thank you. Yeah, I work with Southern Community Mental Health and just spent a few months with the Salem project team setting up the model of care for the new mental health rehab unit, and had the pleasure of working in that unit this week to cover a colleague. So it was fantastic to see that new facility open. So that's not my slide. Where do I go down?
The down button.
Yeah. Okay, let's see if that works. So I'm talking about some practical approaches that you can implement in your practice to optimise medications, and how these can support the equally well principles. And the down button does not like me. Okay, so how can medication optimisation support equally well? By supporting people to take the correct medication, by supporting medication concordance, reducing side effects both long and short term, and management of psychotropic-induced chronic disease and management of psychotropic polypharmacy. So one tool that we can use to support people in taking the correct medications is by doing a best possible medication history. These are routinely done in hospital practice with pharmacists. However, depending on your service in the community, you might not have access to that, or you can access an accredited pharmacist who can have be Medicare funded to do a home medicines review. A best possible medication history is a snapshot of a person's actual medication use at that point in time, and it provides an accurate list of their medications, and this can then be used to guide decision making about what to prescribe. There is a national standard that when taking a best possible medication history that there are 2 sources at least, and this can include the person themselves or their carer, their own medications, a dispensing list from their community pharmacy or the GP list or any specialists, and the My Health record. Any historical adverse drug reactions or events and allergies should also be recorded in a best possible medication history, and it's important that these are updated regularly, especially before and after transfers of care and when there are changes in medications. So how does a best possible medication history help people? Well, the Australian Commission on Safety and Quality in Healthcare has published some data on this. Did you know that more than 50% of medication errors occur at transitions of care, and that patients with 1 or more medicines missing on their discharge information are more than 2 times more likely to be readmitted to a hospital than those with correct information on discharge? Furthermore, 85% of discrepancies in medication treatment originate from poor medication history taking, and between 10 to 67% of medication histories have at least 1 error, with up to 33% of these errors have the potential to cause patient harm. So best possible medication histories therefore reduce prescribing errors. They can ensure that people have access to the correct medications during hospital admissions and at transfers of care, and they can prevent hospital admissions and readmissions and ensure continuity of care and prevent medication-related harm. Other tools to support people to take their correct medications include medication lists, and there are some paper tools freely available on the National Prescribing Service website, including the medication list pictured, and that can be pre-filled out. You can print it out, the template, and then people or their carers can fill it out. Sorry, I'm trying to get this to work. There are some apps as well, subscription apps via the MedSafe or a free app through the NPS website again, and they're freely available. They're available to download on the App Store and Google Play. Supporting medication concordance is another medication optimisation strategy. So this can be inquiring about barriers for taking medications, considering whether supports for taking medications required, such as visual cues or reminders, so that could be around the house or on the fridge, in the kitchen. Medication alarms, like the one pictured, they can be timed to alarm at the times of the day that medication doses are due. Various dose administrations aids, so we might be all quite familiar with the blister style one pictured in blue where people push the medications through, and the ones from community pharmacies that some can have the days of the week and different times of day for doses that can be packed by a person or their carer. There's also the tab timers. These can be quite expensive. Not all pharmacies offer this service, but it basically can be programmed to release the medication at a certain time of day as well. And as mentioned before, medication lists and reminder apps can also support people. Simplifying regimens where possible is a really straightforward approach. If someone's taking a medicine multiple times a day, maybe there's a slow release option available so they can take less tablets and reduce that pill burden. Education is another important part of supporting medication concordance, and this should be a discussion around the indication for the medication and side effects, and then followed up with provision of a consumer medicines information that covers what to do if someone experiences a side effect. We're really lucky in SA Health that we have subscription to Choice of Medications. It's a UK resource, and we've made this freely available and accessible to our patients and their carers. And this can be you can print leaflets that can be tailored to the health literacy of the person, and there's various languages as well, and lots of fact sheets about side effects and other things as well. The importance of constipation prevention and early intervention should also form part of any medication education. Most health services will have some local guidelines about psychotropic-induced constipation. The SA Health ones are freely available on the clozapine webpage. And talking about strategies for managing side effects should form part of this education, including any non-pharmacological approaches. And a common example that we use, if clients who experience hypersalivation on clozapine, we may suggest using pillows to sleep propped up. Reducing side effects, both long and short term, is an important part of medication optimisation. So this includes that proactive monitoring that is recommended. So you're probably, for GPs out there, very familiar with the required monitoring requirements for antipsychotics, so cardiometabolic screening, FBE, liver, renal, prolactin levels, educating and screening for sexual and reproductive side effects. These should be done 6 monthly, or as per your local clozapine guidelines. And then for mood stabilisers, therapeutic drug monitoring to ensure drug levels don't end up toxic and increase risk of toxic side effects form part of that. FBE, liver, thyroid and renal. Importantly, vitamin D and bone mineral density screening for some of these as well. So management of psychotropic-induced chronic disease can also support medication optimisation, looking for signs and symptoms of these regularly, and then undertaking early intervention and proactive referral and optimising that treatment and regularly reviewing for the various cardiometabolic diseases that we're all familiar with. With obesity, I think we should start thinking about the place in therapy for the GLP-1 analogue therapies if they're not cost prohibitive. If you look on the clinicaltrials.gov website, there are some trials occurring worldwide now looking at the place in therapy for mental health populations and people with schizophrenia, and it'll be interesting to see what data comes out of that. For some mood stabilisers, considering osteoporosis prevention with long-term treatment, we should be starting vitamin D and calcium supplementation as soon as those mood stabilisers are commenced. And the RANSCAP guidelines, or consensus statement, on physical health for consumers with complex psychosis. For those who do not engage with a GP, the management of all physical health needs should be addressed by a treating team. That can be challenging with the various resources of different services, but it's a consideration when we're looking at how we can improve our services moving forward. Management of psychotropic polypharmacy includes deprescribing those short-term or as when needed medications, and commonly in acute settings, benzodiazepines can be commenced for short-term use after admission, and same with those short-term antipsychotics. It's important that we review when they need to stop. And understanding that high-dose and off-label prescribing of antipsychotics, so polypharmacy of antipsychotics, or more than one antipsychotic, or high-dose prescribing, is off-label because it's not approved by the Therapeutic Goods Administration for that dose or combination. There's lacking evidence to support any benefit or safety. So it's important in these cases that we obtain consumer consent, document the plan for monitoring, and ensure follow-up on any adverse events and clinical benefit, and communicate this with other primary carers so they can alert the treating team if any adverse events do occur, and make sure, importantly, that this is done collaboratively with the person as well and documented, and just so they understand clinical indicators of response and the plans for review of ongoing need and benefit and risk for ongoing treatment. So thank you for listening. If you're interested for any resources to support medication optimisation, let me know. Cheers.
Thanks, Claire. Taking on a big topic.
Yeah, in 10 minutes, I know.
I'm sure people can come and speak to you if they've got questions and things, and I think you raised a number of the things that Scott Clark also raised in his presentation earlier this morning in terms of the use of things like metformin, thank you.
Yeah, GLP-1.
Metformin and the GLP-1 analogues, and how they're probably going to have a bigger role, but also highlighting, I think I'm taking Chair's prerogative at the moment, and the importance of managing constipation, and one of our dietitians talking about it before and things, and you know, it's just something that we can't avoid to, it's something we should really pay attention to. But thank you, and I'll ask everyone to thank Claire.
Thank you.
And we have our last speaker. We've had wonderful talks this afternoon, and Amrita is our last speaker today. She's going to talk about a research project that she is currently working on
We'll just change the slides over. Looking at the role of physical healthcare navigators.
No, that's not me. It should be a does pharma. Oh, maybe. Yeah, that one. Thank you. Nope, that's not me. That's my name. Yeah, that one. Yeah, thanks. Sorry. I presented in the room next door and the computer system shut down, so I'm hoping it's not me. That's. Okay. Thank you, everyone, and thank you for staying. I know it's the end of the day, and so I'll try to get through this quickly. My presentation is on the project that, as Amanda said, I'm working on, and it's looking at the concept of the physical healthcare navigator, particularly in rural and regional Australia, and testing comparing peer and carer and clinical navigators within 4 different contexts. So I'll just go through the lived experience involvement in the development of this project. To start with, I'd just like to acknowledge the traditional custodians of the lands on which we stand today, the Kaurna people, and pay my respects to elders past, present and emerging, and extend that respect to all First Nation peoples here today. I'd also like to recognise the individual and collective contributions of those with the lived experience of mental health conditions and distress, and those who love and care for us. These perspectives and insights are essential to shaping services, policies and programs that truly meet the needs of individuals and communities. So this project actually originated through the development of the 2022 Equally Well Roadmap, which demonstrated a lack of evidence of the efficacy of peer or lived experience navigation as opposed to clinical or nurse-led navigation of the healthcare system. This project aims to address this lack of evidence, bringing it into the realm of consumers and carers' experiences, and address rural and regional workforce issues. So the Mind and Body Care Navigators project is a multi-stage project culminating in a 6-month regional trial, and we're on the cusp of doing that at the moment, comparing the effectiveness of peer workers, carers and clinicians as navigators to improve access to preventive health care for people with mental health conditions. Why is this important? All day we've been looking at different statistics about the big gap in terms of mortality. These are only some of the statistics illustrating the higher morbidity of those of us with mental health conditions due to physical health issues. As you can see, these numbers are concerning, especially when free screenings and vaccinations can help reduce the mortality rate. Our hope is that this trial will be a game changer in improving access to preventive physical health care for people with mental health conditions, particularly in rural and regional Australia, where there's sparse services and other infrastructure issues can impact on access, leading to avoidable deaths from conditions like cancer, diabetes, and heart disease. Lived experience expertise has been at the heart of this project. This visual demonstrates an image of the project's governance structure and demonstrates how lived experience has been central to the project from the very beginning. So the yellow circle in the middle represents the Lived Experience Leadership Team, or the LELT, as we're fondly called. So this structure actually went into the grant, what was part of the grant application to the NHMRC. So co-design and co-production in this project has been dynamic and at times challenging. The focus has been on progress, not perfection. It has been a learning process for both the Lived Experience Leadership Team and our partner academic investigators. There have been a number of challenges that have meant that at times it didn't feel like we were being authentic to true co-design principles. These include time. It's been a very tight project timeline of 3 years, so we're coming into the final year now. Budget constraints have also impacted lived experience participation as well, and so in order to sustain and keep lived experience central to this project, we've had to be agile in our approach, for example, reducing the number of remunerated meetings and communicating in other ways to meet the project needs. And logistical issues have also raised limitations, such as staffing changes and coordinating between a large group of people across Australia. And it's not just the lived experience leadership team, but there's also the academic researchers and also our advisors. So it's almost about between 40 to 50 people, I'd say, that are all involved in this project. So keeps me busy. There has been a concerted effort, however, to problem solve and address these challenges as much as possible, and the project's successes demonstrate the collaborative effort between the academic investigators and the LELT to overcome project limitations. Some of these achievements include a shared leadership model that was implemented from the very beginning, and this has allowed diverse lived experience members to lead project stages as chairs and co-chairs and provide expertise crucial to the work of the project. The following slide illustrates this leadership model. So it's a very busy slide, as you can see, but members of the LELT have led each stage of the project, ensuring diversity, distributed leadership, and skill sharing opportunities. And we've been working in partnership with our academic research partners. Other achievement includes the development of an out-of-session work policy, which invites LELT members to undertake work crucial to the project, and there's some of those examples there. So this is outside of scheduled meetings, and if people are interested and have the capacity to do that, we've been able to accommodate that. Also, the recruitment of a lived experience research assistant, and full disclosure, that's me. This supports the transition of lived experience advisors in an advisory group in co-design projects to employment as lived experience researchers, and should be considered as a pathway in other co-production work. And finally, the lived experience leadership team led a change of the project name. We strongly felt that the original project name, Physical Healthcare Navigator, did not reflect the duality of individuals dealing with both mental and physical health challenges, and engaged in a co-design process to change the name to Mind and Body Care Navigators. Ultimately, this project aims to empower individuals in their own choices and decisions regarding physical health. Changing the mortality rate for those of us grappling with mental and physical health conditions will only happen when we make it happen for ourselves. Lived experience expertise should lead the way, as has been modelled through this project, and hopefully will ensure it is embedded within the design of the new model of care and its success. And I'd just like to thank everyone on the project team, that includes Amanda as well. In particular, the LELT, the Lived Experience Leadership Team, our co-leads Russell Roberts and Tim Heffernan for their steady guidance and vision. And if you'd like any more information, please email me. Thank you.
Thank you, Amrita. That was also another whirlwind tour, but I think we've had really fantastic presentations this afternoon on a range of topics, and all of them focused really on everyone's passion, I think, about tackling physical health and actually improving outcomes, well-being, health and well-being outcomes for people who experience mental ill health. So I'd just really like us to join together to thank Lisa and Mai, who isn't here anymore, Smonda and Lucy, Stephen, Claire and Amrita. Thank you. And now I think it's the networking function, but thank you, everyone.